चेक। हेलो। सर चेक। सर ऑडियो आ रही है? हेलो, साउंड चेक। बोलना नहीं लगा। चेक, साउंड चेक। इसमें तो डालो ना ऑडियो, यहाँ कहाँ आ रही है? उसमें वो जो बजता है टिंग टिंग टिंग, लैपटॉप को नहीं बजता हो? नहीं, वो बजना चाहिए ना, मैं बाद में बोलूंगा ना। चेक, साउंड चेक। अरे वो बजता है ना अपने जूम में। हाँ हाँ, वो म्यूजिक कहाँ बज रहा है? वॉल्यूम को खोलो। बोल। लैपटॉप का ये जब तक नहीं जाए नहीं, बस तो वॉल्यूम तो खुला हुआ है। नहीं, खुला हुआ है बस।
Hello, sound check. Hello, sound check. Check 1 2 sound check 1 2 3 4 5 6 7 8 9 10.
Significant family history. The ultrasound biomicroscopy showed a very homogeneous mass, and on OCT, the mass was touching on
Can you put the presentation once? I just want to check the presentation. Presentation, not this. There's a PPT also that you have. उधर है?
A very good morning. We'll start off the first session of the last day. And this is a special session where we'll be playing the best of e-posters and e-cases, which have been judged, which were playing in the theater. To chair this session, I'd like to invite on stage Dr. Victoria Dai and the moderator of the session, Dr. Kaustav Mule. The top videos of each session, the e-cases and the e-posters will be played, and the winners will be presented with a medal.
We'll play the video first, then the presentation. Yeah, so first we'll play the e-posters video. That is there available with you.
My name is Carol Shields from the Oncology Service at Wills Eye Hospital. I'd like to talk to you about impact of iris color on uveal melanoma outcomes in over 7,000 patients from our center. Does iris color even matter? It does. Does iris color promote a risk for uveal melanoma? Well, if we go back to 2006, Archives of Ophthalmology, a review of 132 published reports, meta-analysis, light eye color was a risk for the development of uveal melanoma. So this meta-analysis yields strong evidence that light iris color was important. So blue iris was at 1.75 hazard ratio for uveal melanoma. And this was found also in the Netherlands, looking at iris color and risk of developing uveal melanoma. They found green iris at 3.6 hazard ratio and blue iris at 1.4 hazard ratio for uveal melanoma. Questions answered. Now, does iris color promote a risk for melanoma-related mets or death? So the Boston team looked at this in Archives of Ophthalmology 1999. They found patients with blue iris and melanoma had a 1.9 hazard ratio for uveal melanoma metastasis-related death. And the German group looked at the same issue and found that patients with blue iris at a 2.3 times hazard ratio for melanoma-related mets and death. And then from the Netherlands, Ophthalmology 2021, in conjunction with our team, we found that patients with blue iris and mutations of chromosome 3 and 8 have a greater impact of worse prognosis. So it seems like some of those questions were answered. Now, does iris color correlate with skin color? Usually it does. Blue iris is usually fair skin. And can we use skin color to estimate risks? Well, Negretti et al. From our team looked at this and published in Eye 2023, a comparison of Fitzpatrick's skin color, 1, 2 versus 3 to 5, and found that TCGA group D tumors were more often seen in patients of fair skin color, group type 1. And they had a higher risk for metastasis. So they said skin color could be a predictor of metastatic disease. So very light skin, correlate or surrogate for blue iris, more likely to have TCGA group D and greater risk for metastatic disease. That was very similar to the analysis from the Netherlands. And here's the Fitzpatrick skin type 1, 2, 3, 4, 5, showing the skin and the related uveal melanomas in each skin type. One being at highest risk for metastatic disease. So in this analysis, we looked at iris color. Does it impact outcomes on uveal melanoma? We looked at over 7,000 patients and compared iris color blue versus green versus brown for uveal melanoma metastasis. So if you look at demographic features, we found mean age to be a little bit older in patients with iris color blue, and male, a little bit more common in patients with iris color blue, and a little bit more Caucasian in iris color blue. These were all significant. If we look at clinical features, we found less melanocytosis in iris color blue, thinner tumors, more posterior in iris color blue, significantly, and more amelanotic. So let's jump to outcomes. Looking at all the various outcomes, we found patients with blue irides had really no difference in risk for metastatic melanoma to any site, and really had borderline greater death rate than the green or brown iris colored patients. And here's our outcome of uveal melanoma related metastasis over time, showing green, blue, brown. The p-value was not significant, no difference. And when we looked at multivariate analysis, we found that thickness, subretinal vitreous hemorrhage, Brakenbrooks membrane, and primary nucleation at greatest risk for metastasis, but iris color did not impact metastatic disease or death. So for 50 years, we have documented iris color in our charts, and we think it's very important. Right here is where we mark iris color, melanocytosis, heterochromia, color, and the Fitzpatrick skin type. So in this analysis, iris color did not really impact metastasis and did not really impact death. So does it even matter? Yes, it does matter. It matters because it matters in the risk for the development of uveal melanoma, most likely. Maybe not so much for the risk for metastasis, but it could if you think about skin color related to iris color. Thank you.
Can I request the chair to please announce the judges for the E.
I thought that you want us to do it at the end. So. Okay, so the winners for the e-posters for uveal melanoma. So third place would be Carol Shields. Does uveal okay, you want to talk? Does uveal melanoma tumor size matter? Not the one we saw. Second place was Arun Singh. A predictive model for iris melanoma. And the winner video we just saw, Carol Shields, impact of color on uveal melanoma outcome in 7,245 patients.
Dr. Rolika will take on the behalf of Dr. Carol Shields. Is there anybody who would like to take on behalf of Dr. Arun Singh the medal?
Hello, I'm Colleen Sevilla, and I will talk about genetic testing results for uveal melanoma patients in the context of NCCN and ASCO guidelines. I have no disclosures. I'd like to thank my collaborators and funding sources. About 10% of uveal melanoma patients have evidence of a dominant high penetrant gene that predisposes them to uveal melanoma. This can be uveal melanoma and other cancers. We can see a pattern of cancer in many of these families. And the TCGA has identified some of the genes that are important. These are germline alterations, for example, in BAP1, POT1, and BD4. Our group has also published on some of the genes that underlie hereditary predisposition for uveal melanoma. And these are patients with strong family history or familial uveal melanoma, congenital melanoma, different cancers. So we can especially see BAP1, PALP2, MLH1, and then many other genes. So what's the level of evidence for different genes in terms of predisposition? So BAP1 has definitive evidence of causing or predisposing to uveal melanoma, but based on the limited number of publications and types of evidence, there's moderate evidence for these two, MBD4 and PALP2, and then there's limited evidence for many other genes. And so we really want to get more data on these kind of things. So what about guidelines? Who of our patients with uveal melanoma should we send for genetic counseling and testing? So there are a couple guidelines. One is from the American Society of Clinical Oncology. They recommend BAP1 germline testing for patients who have a personal or family cancer history at risk for hereditary, the BAP1 hereditary syndrome. There's also the National Comprehensive Cancer Network, or NCCN network guidelines, which recommend referral to genetics in patients with an early age of diagnosis, so age less than 30, history of other primary cancers, or family or personal cancer history associated with hereditary syndrome, specifically BRCA and PALP2 and BAP1. So our study purpose was to evaluate the outcomes of clinical testing for patients with uveal melanoma who met clinical criteria and were referred for genetic counseling. Our criteria of who we referred for counseling was more broad than the NCCN and ASCO guidelines. So we had a broader age range. We included people who were 50 or less, and other primary cancers, not just the BRCA, PALP2, BAP1 cancers were included. These patients were offered large panel testing by the genetic counselor, and we had an IRB approved retrospective chart review of the results. So what we identified was that of the 74 patients who were referred for testing and counseling, 16% had a pathogenic or likely pathogenic germline alteration. And all these patients met NCCN criteria. And these are just some of the genes here. So actionable genes include BAP1, BRCA1, BRCA2. And in terms of potentially actionable, we found POT1, XRCC2, and then also BLM and MUYTH. Although they are actionable if they have 2 copies. Our patients had only 1 copy. So just to highlight a couple of the patients, one of the patients here had BAP1 germline alteration. So this patient presented to our clinic with uveal melanoma, also had a endometrial cancer at a young age, basal cell carcinoma, and a kidney lesion. But the family history is very significant, including for a niece with uveal melanoma at age 19, with metastasis, cutaneous melanoma, mesothelioma, brain, thyroid, liver, lung, breast cancer in the family. And this is another patient. So this patient has germline alteration POT1. They presented with uveal melanoma in their 60s. They also had a bilateral synchronous lung cancers, and also family history of lung cancer and throat cancer. So in summary, there is epidemiologic and genetic evidence to support hereditary cancer in uveal melanoma patients. It's diverse phenotypes, and there's a lot of locus heterogeneity, so genetic heterogeneity. In terms of the NCCN criteria, we found that 16% of these patients meeting the criteria had pathogenic germline alteration, with 11% potentially actionable. We recommend using a large panel test, not just BAP1 testing only, due to the genetic heterogeneity. And so far, only BAP1 has definitive genetic evidence for an association with uveal melanoma. So if you identify anyone with a germline alteration, please publish or collaborate to get these data published. Thank you so much.
So for this session, uveal melanoma and other intraocular tumors, the third place is shared between Dr. Alex Malat and Michelle Hifman, and their videos are online, so you can see them at the app, I mean. And the second place was given to Dr. Scott Oliver. Is he here? Okay, so he's getting a medal. Who would like to collect it in his name? Endodiode laser thermotherapy and vitrectomy retinal biopsy for the treatment of small uveal melanoma, initial results. And we heard Dr. Colin Kabula, genetic testing results for uveal melanoma patients in Connecticut on NCCN and ASCO guidelines. So is she here? No, she's also not here. So maybe we could go on and just give them the medals later. Can we go on? So this is for.
Thank you for the opportunity. I will be presenting my poster titled Morphological Characteristics and Longitudinal Structural Changes in Choroidal Osteoma, a Multimodal Imaging Study. I have no financial disclosure. As we all know, choroidal osteoma is a benign ossifying tumor characterized by mature bone replacing underlying choroidal structures. However, in few cases, particularly 1/3 of cases, choroidal neovascular membrane can be long-term sequelae, leading to detrimental vision loss. The aim of our study was to analyze the clinical profile, multimodal imaging features, and longitudinal changes in choroidal osteoma in a large cohort of Indian patients. It was a retrospective longitudinal observational study where patients' data were retrieved from electronic medical record, baseline demographic findings, clinical features, imaging, especially on OCT and OCT angiography, treatment and follow-up were documented for all the cases. New definition about deossification, which includes absence of an osteoma lesion with visible choroidal vessels and thinning of the choroid, was suggested. Whereas RP atrophy was defined as yellowish white discoloration seen as hypoautofluorescence on fundus autofluorescence and transmission defect on OCT without disossification. In terms of results, a total of 65 eyes, 52 patients, 17 males and 35 females were included in our study. The mean age of presentation was 32 years. Three different zones could be identified in most of the choroidal lesions. They were kind of classified as deossified area, an ossified area with an overlying retinal pigment epithelial atrophy, and an osteoma without overlying retinal pigment epithelial atrophy. And this was the first time that we have kind of come out with an OCT-based and fundus photo-based correlation between these three different zones. In terms of OCT-based imaging features, what we could see in our study, first was retinal pigment epithelial atrophy. This was usually seen as a kind of pigment epithelial atrophy leading to ellipsoid zone loss and outer retinal as well as outer choroidal layer structure deformity. And when we compared patients with RP atrophy, where as compared to patients with no RP atrophy, there was no significant difference in between terms of age difference between the two groups. However, when we could see the deossification, which was seen in 1/3 of cases, when we compare patients with deossified areas, they were significantly older as compared to patients who had no deossification. And this was statistically significant. So this kinds of denotes that deossification can be one of the chronic changes which happens particularly in older subjects. And when we do the OASU curve, it was denominated at 0.66 with a p-value of 0.01 with a cutoff value of 29.5 years. The second was the choroidal neovascular membrane. This was again seen in close to 1/3 of cases. On fluorescein angiography, it showed a kind of early hypofluorescence and late leakage, because demonstrating classic type of choroidal neovascular membrane. And on OCT, it showed presence of type 2 CNVM with surroundings of retinal fluid and intraretinal fluid. In few cases, particularly 5 cases, 8%, we could see there was presence of subretinal fluid, but there was absence of any choroidal neovascular membrane, again suggesting the growing nature of choroidal which can lead to presence of subretinal fluid without CNVM. Few cases, particularly close to 50% of cases, we could see hyporefractive cavitations, which were seen particularly at the level of chorocapillaries. And when we kind of looked at this lesion and when we did kind of multivariate analysis, we could find that this hyporefractive cavitation was usually seen in patients who had ultimately undergone deossification. This could be one of the significant biomarker. Focal choroidal exacerbation again was seen in close to 40% of cases, and this denote again chronicity, which was seen in case of choroidal osteomas. OCT analysis, as you could see, this was seen in performed in 31 eyes, and we could see the focal chorocapillary loss, which was seen in all the eyes, with extensive loss seen in patients, especially with had choroidal neovascular membrane and deossification. In terms of longitudinal changes, out of 15 eyes, 2 eyes, and increase in lesion size over a mean of 14 months. As you can see in both the corresponding fundus photograph, there was a growth of choroidal osteoma with presence of subretinal fluid, whereas in 10 patients, there was a decrease in size of choroidal osteoma with increase in RPE atrophy, deossification, appearance of osteoclastic clefts. These are the few limitations, and I have to conclude where deossification, RP atrophy are two independently occurring processes. Hyperreflective cavitations could be one of the earliest signs of deossification, and younger patients with choroidal osteoma experience an increase in lesion size. And the frequency of CNVM is very high, especially in cases with choroidal osteoma. Thank you for your patient listening.
So you can see the other winners in this category of e-posters, intraocular tumors. So number one prize goes to Dr. Vishal Raval, but I understand that he's
I'll request Dr. Praneeth to correct on his behalf, please.
morphological characteristics and longitudinal structural changes in choroidal osteoma, multimodal image study. And then prize number 2 goes to Aliama Sarjul Cesur, mid-88 and L265 mutations in cell-based and cell-free DNA in the blood of patients with biopsy-proven vitreoretinal lymphoma. Is she here? Okay. And then prize number 3 to Ruji Udart, many facts on congenital hypertrophy of retinal artery. Okay.
Dr. Praneeth will collect on behalf of Dr. Vishal Raval. Can we request to have all the winners on stage for a group photograph, please? And I request all the winners to remain on stage and take a group photograph with the chair and the moderator.
Thank you to the program committee for the opportunity to present our findings on improving retinoblastoma imaging. Here are my disclosures. The purpose of this project was to investigate possible improvements in ocular imaging, taking advantage of a concurrent liquid biopsy experiment. Our animal model has been described previously. We implanted human retinoblastoma cells under the retina after immunosuppression. Then, over a 4-month period, we scanned the rabbits every 4 weeks with a 4.7 Tesla MRI and used this 40mm surface coil that's placed circumferentially around the eye. This is the current state of ocular MRI imaging. You can see improvement from a 1.5 Tesla image on the left to the 3 Tesla image on the right. We can further improve the quality by using a 3D acquisition technique on the right. Here you see the significant improvement that we obtained, even though the rabbit eye is half the size of the human eye. With our technique, you can see intricate details of the iris, the anterior chamber, the posterior chamber, the ciliary body, and the sclera. The 3 layers of eye are seen separately, much like you would see in a histologic specimen. The inner retinal layer, the choroid, and the sclera separately. We had 2 rabbits in this experiment, and due to time, I'll show images from the first rabbit. At 1 month, you can easily see the vitreous seeds on the axial images and the exophytic retinal tumor. The coronal images were of high quality, demonstrating diffuse vitreous seeds here. And as you scroll back, you can see the retinal tumor in the back of the eye. And we can see the signal change within the optic nerve, representing post-laminar optic nerve invasion. Post-contrast images demonstrated robust normal ciliary body enhancement. However, there was minimal to no enhancement within the tumor or the optic nerve. Tumor growth was significant in the 2nd month. The arrow is on the enlarging retinal tumor. We now see choroidal tumors forming both superiorly and inferiorly. Again, the tumors did not avidly enhance. At the 3rd month, all the tumors grew. There are areas where you see the invasion of the scleral layer. The interchamber invasion is now seen. The optic nerve is grossly enlarged with tumor. Again, the large masses do not show robust contrast enhancement, and neither does the optic nerve. Histopathology confirmed invasion of the optic nerve by tumor. You can see how similar the MRI image is to the gross section here and here. Histology confirmed the massive tumor invasion of the optic nerve, retina, and the choroid. So here are my conclusions. First, we can significantly improve clinical MRI scans if we utilize a small surface coil placed directly on the eyes. Even with available 3T magnets, this would be possible. Unfortunately, most orbit MRIs are being done with the head coils that are designed to image the brain. Second, I think paralysis is important in getting high quality orbit MRI. You can see a difference between the non-paralyzed rabbit on the left compared to the one paralyzed on the right. Finally, enhancement was not particularly a good sign of tumor or optic nerve invasion. With enough resolution, you can see the mass structurally invade the optic nerve, the sclera, and the other structures. With enough resolution, enlargement of the optic nerve may be a more reliable sign of invasion. Thank you for listening to this presentation, and hopefully we can improve ocular MRI imaging for our retinoblastoma patients in the future.
So in this session, we have a tie for the 3rd place, shared between Arun Singh and Dr. Ashwin Malpinta. So Arun Singh is evaluating evolving criteria for Group B retinoblastoma, and Ashwin is AJCC staging retinoblastoma, review of literatures, and proposal for change of staging of retinoblastoma. And then the two prizes goes to place number 2 for Kushal Agarwat, clinical profile and outcomes of retinoblastoma in preterm babies. And we just heard Dr. Stefan Chen's beautiful presentation on high field strength MRI for visualizations of fetal seeds, choroidal invasion, and optic nerve invasion in retinoblastoma animal model. So
The awards were on behalf of Dr. Chen. Dr. Dan will be taking one award. And we have Dr. Mritika Sen who will be taking the award on behalf of Dr. Kushal Agarwal. The second prize.
Greetings. My name is Riya Sachdeva. I am a PhD scholar at Dr. Shroff's Charity Eye Hospital in New Delhi, India, and will be presenting this poster on the topic, Targeted Whole Exome Sequencing Reveals Mutation Clustering for Pathogenic Genetic Variations in RB1 Gene in Retinoblastoma. Retinoblastoma is the most common yet treatable pediatric ocular malignancy of the retinal layer of cells. It is estimated that India has the highest disease prevalence with about 1,200 new cases each year. In majority cases, it is caused due to biallelic inactivation of the tumor suppressor gene RB1, which consists of 27 exons with no specific hotspots. The progression of cell cycle is controlled by its binding status with E2F transcription factors. The Knutson's two-hit hypothesis helps explain the difference in age of onset and laterality of the tumor based on the timing of allelic variation events in RB1 gene. This study aimed to analyze the molecular profile of 200 RB patients from North India and the genotype-phenotype correlation observed in the cohort. For the 200 RB patients enrolled, targeted RB1 analysis using NGS and MLPA was performed on blood sample of patients. Phenotypic parameters recorded were as listed. Fisher's exact test and Kruskal-Wallis test were used respectively for the categorical and continuous clinical parameters to check their association with the mutation type. Data from 200 RB patients, including 113 unilateral, 85 bilateral, and 2 trilateral patients, was included in analysis. The male to female ratio was 1.35:1. 94% cases in the study were isolated or sporadic cases, with only 12 individuals displaying family history of RB. The noteworthy observations in result include the overall detection rate of 48% among the 200 patients tested. The median age of onset at 8.5 months was the lowest observed among patients with splice site variants when compared against patients from across all other categories. A marked 43% bilateral RB patients exhibited nonsense variations in the RB1 gene, marking this as the only parameter with statistically significant association with genotype. All cases of large deletions and duplications were de novo. Though statistically significant, there was a trend towards patients from nonsense variation group experiencing more metastasis and recurrence. This is a graphical representation of the site of mutation across all exon and introns of the RB1 gene. A potential mutation hotspot in the RB1 gene between exon 14 and 21 mutations in this region were found in 57% of the patients, including 6 of the 12 familial cases. In conclusion, this is the largest cohort study analyzing the genotype of RB patients in a unique population subset from North India, highlighting the regional variation in phenotype. About 15% of the bilaterally affected patients had no identifiable mutations in RB1 gene. This could be due to phenomena such as low-level mosaicism or presence of deep intronic variants. The significance of identifying a mutation hotspot in a cost-limited setting like India could translate into developing testing methodologies like long-range targeted PCR. I would like to thank our mentors and colleagues for their continued support and encouragement during this study.
So we heard the presentation by the winner. Dr. Ria Rotana will give her the medal shortly. Second place goes to Dr. Aprama Ramasubam. I'm sorry to know. You can.
Okay, Dr. Aparna Ramsubramaniam, and the third one goes to Dr. Matthew Wilson.
Are they here?
I'm going to talk today about the role of BCOR in retinoblastoma. BCOR mutations are relatively common in retinoblastomas. They're the second most common alteration after loss of RB itself. And they're associated with markedly more aggressive biology with invasion of the choroid and optic nerve. We looked at a panel of retinoblastoma cell lines and found that several of them, including wary RB1, had a lot of BCOR protein expressed, whereas others, such as Y79, had little or no BCOR protein. And so we knocked BCOR out in some of the cells that had high levels to start with and found that knocking it out results in acceleration of growth, as shown in this growth curve on the right. In contrast, overexpressing BCOR protein in Y79 cells that don't have any at baseline suppresses growth. Now, similar effects were seen on clonogenic growth with a dramatic induction of clonogenicity in multiple lines after BCOR knockout. The same relationship held true when we look at invasion and migration, where BCOR knockout dramatically promoted migration and invasion, whereas BCOR expression dramatically inhibited invasion and migration. These in vitro findings were also true in vivo. Here we're looking at orthotopic xenografts, and these intraocular tumors were much larger and more invasive after BCOR knockout than in the control cells expressing BCOR. The same was true in flank xenografts. You can see here that after knockout, there was much more dramatic growth of the flank xenografts as compared to the parental cells with higher BCOR levels, and the opposite was true when BCOR was overexpressed. Now, we identified IGF-1 as a possible downstream mediator of these effects. And you can see here that knocking out BCOR was in multiple lines resulted in a dramatic induction of IGF-1 expression, whereas overexpressing BCOR suppressed IGF-1 expression. And this was true not just at the mRNA level, but also at the protein level, as shown on the right. And it resulted in phosphorylated inactivation of the IGF-1 receptor. Using drugs such as lincitinib that can inhibit IGF-1 receptor, we found that in all the cell lines tested, low levels of BCOR that increased IGF signaling sensitized the cells to lincitinib as compared to controls with higher BCOR levels. And this was due, at least in part, to induction of apoptosis. This was also true in xenograft models. We see here that parental wary cells are insensitive to lincitinib, but after BCOR knockout, they become quite sensitive to lincitinib, and the opposite is true when BCOR is overexpressed. That will insensitize the cells to lincitinib. So to conclude, B-core loss is associated with increased growth and invasion of retinoblastoma cells in vitro and in vivo. This is due at least in part to increased IGF-1 expression and IGF-1R receptor activation, and that inhibitors of this IGF-1 signaling cascade show great promise as novel therapies for aggressive B-core mutant tumors. Thank you, and I wanted to acknowledge the work of Suchan Lee on this project.
Okay. In this category of e-posters on retinoblastoma, the third prize is shared by Dr. Swati and Dr. Dennis. The second prize goes to Dr. Ashwin Reddy, and the second prize is also shared with Ms. Brian Brown, and the first prize goes to Dr. Charles Eben.
Dr. Berry will collect on behalf of Dr. Brianne Brown. And can we have the chair and the moderator to join the winners for a photograph, please?
On behalf of my co-authors, I would like to thank ISO-Goa for the opportunity to present our work. I will be talking about the role of kinase inhibitors in low-grade ocular malignancies. We have no financial disclosures. The mitogen-activated protein kinase enzymes control cell signaling, metabolism, and division and survival. There are more than 500 protein kinases in humans, classified as tyrosine, serine thionine, or non-specific based on their amino acid specificity. Some kinases are more active in cancer cells, and kinase inhibitors can prevent cancer cell proliferation and also have an anti-angiogenic effect. Kinase inhibitors have systemic uses. They're used in several breast cancers, chronic leukemias, stromal GI cancers, as well as renal cancers and lung cancers. They have adverse effects which are different from conventional chemotherapy. Liver toxicity is a particular problem, and skin problems such as Stevens-Johnson syndrome or paronychia can be quite troublesome. They can also cause GI upset and fatigue. The biggest advantage is that these drugs are not very dose sensitive, and there is no minimum inhibitory concentration, unlike chemotherapy drugs. As a result, even if the patient experiences side effects, the drug dose can be reduced and they will still have a degree of efficacy. We have a few examples of cases treated with such drugs. This boy presented with a plexiform neurofibroma that was growing rapidly. He was treated conventionally with biopsy and debulking of the neurofibroma, as well as chemotherapy, without sufficient relief. With newer treatments such as trametinib, which is a MEK inhibitor, you can see there was a marked improvement in the appearance clinically on the top, as well as on the MRI scan seen at the bottom. This was a boy who presented with extensive cutaneous juvenile xanthogranuloma, and he had undergone previous treatment with steroids, both topical as well as intralesional and systemic, with first and second line chemotherapy, as well as surgical debridement. He was treated with trametinib, another MEK inhibitor, since October 2022, with a marked improvement in the appearance. The final case is of an inflammatory myofibroblastic tumor, a very rare tumor for which there are no known treatments, and surgery seems to be the best option. This was an awkward location because of extension into the superior conjunctival fornix. On biopsy, the tumor was ALK fusion positive, and he was given crizotinib as part of a trial, and you can see the marked improvement in the appearance in the pictures on the top and on the OCT scan below. There are several unknowns about these drugs. We know that they work better in conditions that are time limited and resolved by puberty. We know relapses can occur, but we hope that newer molecules will provide longer-term relief. There may be long-term adverse effects, particularly in growing children. We have now more than 20 years of experience with these drugs, and it has expanded treatment options. In summary, these new drugs have revolutionized the management of conditions like plexiform neurofibroma and other disorders with considerable morbidity, with fewer side effects. Combining surgery with medical management may be feasible, but the drugs remain quite expensive. Thank you.
So for this category on eyelid and orbital tumors, the third prize goes to Dr. Sharmista Behra. The second prize goes to Dr. Shefali Chaher. And the first goes to Dr. Manoj Parulekar.
I would like to share my experience with adjuvant iodide 125 plaque brachytherapy for the management of conjunctival malignancies. These are my financial disclosures. The management of conjunctival malignancies with diffuse conjunctival involvement or scleral invasion is always challenging. The available management options include enucleation versus modified exenteration versus plaque radiotherapy as a globe-preserving option. In this study, we report our 13 years of experience with custom designs conformer and COMS plaques with a radiation dose of 50 gray to a depth of 2 millimeter. In this study, records of patients who had conjunctival plaque therapy at the Kellogg Eye Center, University of Michigan, from October 2011 to February 2024 were reviewed. Diagnosis, follow-up time, recurrence, metastasis, side effects, and treatment outcome were evaluated. We used two types of conjunctival plaques. One, 3D printed, custom designed conformer plaques for diffusely involved conjunctival lesions, as you see in the slide above, and COMS plaques for the localized conjunctival lesions, as you see in the slide below. This study included 19 conjunctival melanoma, 9 conjunctival squamous cell carcinoma, and 2 sebaceous carcinoma patients. In our study, nodular and diffuse involvement were almost equally seen in each cohort of the conjunctival malignancies. Maybe nodular involvement was slightly more. In conjunctival melanoma group, after a median follow-up of 19 months, local recurrence and metastasis was observed in 21% of patients. On the other hand, conjunctival squamous cell carcinoma group, after a median follow-up of 35 months, local recurrence was observed in 22% of patients, and there was no patient who developed metastasis. Sebaceous carcinoma group was very small with 2 patients, and local recurrence was observed in one of them. When we did a Kaplan-Meier analysis, we observed that all local recurrences occurred within first 3 years in conjunctival melanoma patients. On the other hand, all local recurrences occurred within first year in conjunctival squamous cell carcinoma patients. Here you see an example of 68-year-old man with invasive conjunctival malignant melanoma of the right eye. After excisional biopsy, he received 3D custom designed conformer plaque therapy, and after 2 years follow-up, there was no recurrence. This is a 63-year-old man with invasive conjunctival squamous cell carcinoma. After excision, he received COMS plaque radiotherapy, and after 2-year follow-up, there was no recurrence. The most common side effect was limbal stem cell deficiency, seen in 30% of patients, and occurred within a median of postoperative 4 months. Rubiosis iridis and scleral melting was seen 1 patient each within postoperative 7 months. As a summary, brachytherapy for conjunctival tumors seems to be an effective therapy for diffuse conjunctival involvement or scleral invasion in conjunctival melanoma and squamous cell carcinoma. Globe salvage was obtained in 68% of the patients. Thank you very much.
For the category of e-posters in ocular surface tumors, the third prize goes to Dr. Subhav Prasad. The second goes to Dr. Anirudh Herur, and the first to Dr. Hakan Dimikri.
I would like to present the volumetric analysis, adverse events, and patient-reported outcome measures from a randomized controlled clinical crossover trial of 3D printed versus analog ocular prosthetics. The 3D printed process requires an anterior segment OCT, which has been modified with a daylight D50 light source and capable of taking a raw color image. This image is the socket and the fellow eye, and that gives the anterior and posterior surfaces of the prosthetic. Then bespoke software translates that into a 3D printable file, and a medical grade 3D printer manufactures the prosthetic layer by layer. And this has recently been published in a paper just this year. So that allows layer by layer manufacture, as shown in this slide. And the cosmetic results are nicely shown here. We report the results of a masked, non-inferiority randomized crossover trial comparing the fully 3D printed digital ocular prosthetic versus the handmade ocular one. Each prosthetic type was worn for 4 months. Dr. Solomon will present the main outcome measure of motility in a talk during this meeting. The secondary outcome measures are reported now, and that is volumetric analysis, adverse events, and patient-reported outcome measures. In terms of prosthesis volume, volume scans were taken at the start and end of each prosthetic type, and there was no difference in the mean and range of the volumes between the analog and digital types. Adverse events, there were no serious adverse events such as extrusion or exposure of the implant. There were mild device-related adverse events numbering 110 in total, which have been tabulated. And the only significant difference was that there was rotation of the prosthetic eye, more commonly found with the 3D printed prosthetic. Patient reported outcome measures were tested with a cosmetic questionnaire, which was given to the patients, and also the ocularist, and the 9 questions asked could be rated from excellent to unacceptable. And there was no difference between the digital and analog prosthesis for cosmetic outcomes, and no difference between the responses from the ocularist compared to the responses from the patients. Patient-reported outcome measures were also tested on a Likert scale general ocular prosthetics questionnaire, which indicated high levels of satisfaction between both prosthetic types. They were given to the patients at the halfway point and the end point of each prosthetic type, and there were 5 potential responses. The endpoint results are shown here, asking questions about color, shape, fit, and any other symptoms as listed there. The only parameter show a significant difference comparing the midpoint to the endpoint was that the patient's perception of color with the digital prosthesis showed an improvement. Otherwise, there was no significant difference at any time point. To conclude then, the digital 3D printed prosthetic demonstrated non-inferiority compared to the handmade ocular prosthesis in volume change, in adverse events, except rotation was more common in the digital prosthesis, and patient-reported outcome measures. Thank you.
So in the third place, prize was given to Sema Sen, and then the second one to Helen Dimaras, and the winner was Dr. Mandeep Subbu.
Next, we have the best of the E cases, which have been judged by the judges for 3 sessions.
Hello, this is Aparna Ramasubramanian, and we are discussing an infant with an iris mesenchymal tumor. The only financial disclosure is that I'm a consultant with Day One Biopharmaceuticals, and it is not relevant to this presentation. So we're presenting a 10-month-old female who had an amelanotic vascular iris lesion that was first noted at 3 months of age and was slowly progressing over the last 6 months. Her other eye was normal. She was otherwise systemically healthy, and there was no significant family history. The ultrasound biomicroscopy showed a very homogeneous mass, and on OCT, the mass was touching onto the cornea, but there was no corneal involvement. And a left iridectomy with excision of the tumor was performed, and on histopathology, it showed spindle cell neoplasm with a neural phenotype. Occasional pleomorphic cells were also seen. The immunohistochemistry showed strong nuclear SOX10 positivity in majority of the lesional cells. The tumor cells were negative for desmin, smooth muscle actin, and myogenin. We did send the tissue for next generation sequencing, and it showed the presence of WWTR1 and an NCO2 fusion transcript. And we'll talk about that in a little bit. Electron microscopy revealed a population of spindle cells surrounded by a rim of pigmented melanocytes. They showed a very bland nuclei with dispersed chromatin. It was suggestive of a Schwann differentiation, but there was no fibroblastic, skeletal, or smooth muscle differentiation. This is the patient post-excision, close to 6 months. There was no recurrence up to a year, and there was a cataract developing, and of course, there was loss of the iris tissue. So after 1 year of stability, the child underwent iris reconstruction, a pupilloplasty, and a cataract extraction with an IOL placement. Coming back to the WWTR NCO2 fusion, this is a nice description of the next generation sequencing for sarcoma diagnosis. And the fusion that we had seen with this patient has not been reported previously. The WWTR1 is a transcriptional co-activator, and it modulates mesenchymal stem cell differentiation. It has been reported in sarcoma, breast cancer, and hemangioendothelioma. The NCO2 gene, as you can see over here, the arrow pointing, is a nuclear hormone receptor transcriptional co-activator, and it has been reported again in mesenchymal tumors like chondrosarcoma, angiofibroma, and rhabdomyosarcoma. So our child's immunophenotype was not consistent with any neoplasm that has been reported in the literature, but based on the pathology, electron microscopy, and the next generation sequencing, we believe this is in the mesenchymal, it is a mesenchymal tumor. And based on the pathological data and from the clinical data, it is more in the benign spectrum. And this kid is close to 3 years with no tumor recurrence and no systemic manifestations. So we are emphasizing the need for excisional biopsy with ancillary testing to avoid overtreatment by enucleation. This child's retina is completely healthy and has good vision potential. Thank you very much for your attention.
For this category of E cases on uveal melanoma, retinoblastoma, and other intraocular tumors, the third prize is shared between Ms. Hiba Kuhil and Ananya Joshi. Second prize goes to Dr. Carol Shields, and the first was won by Dr. Aparna Ramsubramanian.
I think we can move on because none of them is here.
From the Ocular Oncology Service at Center for Sight, Hyderabad. I thank my mentor, Dr. Santosh Honavar, and our ocular pathologist, Dr. Kaustubh Mule, in helping me putting this presentation together. I have no financial interest to disclose. Before we begin, do we all recognize this picture? Yes, if we do, how about an attention to detail to the pound of flesh? And if yes, then why don't we have an attention to detail for this? And in a busy oncology OPD, many such masses can present to us on a single day in all the different rooms available. What we already know from our literature is caros means flesh, and 96% of these masses are benign in nature, with nevus being the most common caruncular lesion. It is important to duly recognize these lesions to have a protocol-based management and achieve favorable outcomes. Today, we bring to you a 32-year-old young lady who presented with a mass at the inner angle of her eye since the last 22 years, which has been painless and progressive in nature since the last 1 year. On a detailed slit lamp biomicroscopic examination, what was evident is a fleshy, pink, non-pigmented mass with the posterior border not discernible, it being non-tender on touch, soft to firm in its consistency, with no underlying scleral fixity or a change in the prominence of the mass on acute pressure. However, what is really appreciable is a yellowish hue inferiorly and with the cilia projecting from the surface of the lesion as shown or demarcated by those arrows. Clinical acumen made us narrow down our diagnosis to a possible choristoma of the caruncle, a sebaceous gland neoplasm, or a papilloma. However, to achieve a definitive diagnosis, what better than to put the lumbricals of the expert to work, wherein a radiofrequency monopolar electrode is used to carefully dissect the lesion from the surrounding tissues, respecting the oncological principles, and a bipolar electrode is then used for pedicle dissection, lifting off the tissue, followed by reconstruction of the ocular surface using fibrin glue. Histopathological examination showed the presence of keratin horn and presence of glandular tissue, pointing it to be a choristoma. Employing the 5 men of Rudyard Kipling, what do they teach us? It is the presence of a normal tissue at an abnormal location. There are 2 or more tissue elements involved, and hence we termed as a complex choristoma. Why is it important? Because of its association with the possible nevus sebaceous, Goldenhar syndrome, Klippel-Feil syndrome, and many more. And what do we know is the location being the ocular surface or the epibulbar surface being the most common. However, in this case, we have the caruncle. And based on histological classification, a complex choristoma is one which has 2 or more tissue types. One such case at the caruncle has been reported before, and now we bring to you this case in an elderly woman with a complete surgical excision being our go-to option, confirming our clinical diagnosis by histopathological examination and a systemic workup to rule out syndromic associations. Thank you for your patient listening.
This category on e-cases in intraocular tumors, eyelid tumors, and ocular surface tumors, the third prize goes to Dr. Hang Da Chow, Dr. Andre Yaravoy, and the first goes to Dr. Subho.
Hi, I'm Sarah Lally from the Oncology Service at Wills Eye Hospital. Today I'm going to present a 55-year-old woman who noted a spot on the surface of the left eye for 6 months. She was referred to our oncology service, and on higher magnification, you can see a multilobulated gelatinous mass into the inferior fornix with extension onto the lower lid. MRI scan was obtained, which showed enhancement inferior-medially and into the anterior orbit. So previously, we would have exonerated a patient like this. However, now we will biopsy the lesion to confirm the diagnosis of invasive squamous cell carcinoma and send the tissue for biomarker testing. We will refer the patient to medical oncology to start on immunotherapy, and this patient was started on cemiplimab. After the first cycle, the patient felt like her eye was getting better. Her biomarker testing came back, which showed she was HPV negative, tumor mutational burden low, and PD-L1 negative. External photographs show progression of the disease at date first seen, followed by after the third cycle for which she was tolerating well and looks like reduction in the size of the lesion. After the fourth cycle, though, the patient felt like the lesion was getting bigger and was having more difficulty with motility. You can see extension onto the lower lid, which is enlarged compared to after the third cycle, and we were also concerned for progression. But is this progression or pseudoprogression? Well, pseudoprogression is a phenomenon seen with immunotherapy in which there's an increase in tumor size followed by a decrease in tumor burden. It can lead to premature discontinuation of the medication. Pseudoprogression has been seen in other tumors of around and in the eye, including uveal melanoma, skin melanoma, and Merkel cell carcinoma. It is felt that the enlargement of the lesion is due to tumor cell death, which causes inflammation, hemorrhage, and edema, with necrosis, all leading to a pseudo-enlargement of the lesion. We took the patient to the operating room and removed the lesion completely. Only 20% of the tumor showed viable tumor. There have been many recent articles about the use of immunotherapy for advanced squamous cell carcinoma with extension into the orbit, and the debate is still out on whether it works or not. It is felt that higher mutational burden responds better to the immunotherapy. In skin squamous cell carcinoma, the PD-L1 correlated with longer disease survival, but this was not the case with oral squamous cell carcinoma, and it wasn't a predictive of the response to the immunotherapy. PD-L1 also did not correlate with the HPV status. So in summary, this was a 55-year-old woman with extensive squamous cell carcinoma. Biomarker testing revealed low tumor mutational burden, PD-L1 negative, HPV negative, treated with 4 cycles of cemiplimab and was felt to have growth, went for surgical resection, but pathology only revealed 20% viable tumor. And definitely the management of advanced periorbital cancer is changing. I just wanted to also present 2 other patients quickly, which also had similar biomarker testing, who were started on immunotherapy and had either no response or partial response. So we feel that it's going to be a combination of immunotherapy and surgery that leads to the best result for these patients.
This was the last of the kind. This category of E cases in ocular surface tumors and orbital tumors, Dr. Shefali wins the 3rd prize, Dr. Devjyoti Tripathi gets the 2nd, and Dr. Sara Lally wins the 1st.
So I think no, are you going to? Oh, okay.
We have the 3rd prize winner, Dr. Shefali. You can go up for a photograph. Is there any representative for Dr. Lally or Dr. Tripathi? Dr. Tripathi is here.
So we have 15 minutes until the official beginning of the session. Santosh, should we take a break for 15 minutes? Okay.
If the audience has any questions regarding these posters or anything, we can take it up. Or take a break. and then come back for the next session at 9:30. I'd like to thank the moderators and the chair and all the judges for patiently judging the e-posters and the e-cases. The next session is papers on eyelid tumors and orbital tumors. We'll begin that at 9:30. All right, everyone. We are ready to start our next session, which is papers on eyelid tumors and orbital tumors. For this session, I invite our chairperson, Dr. Lakshmi Mahesh, our moderator, Dr. Sonam Poonam Nisar, and our expert panelist, Dr. Charles Eberhardt, Dr. Geeta Vemuganti, and Dr. Jacob here on stage, please.
Hi, good morning, everyone. I'd request Dr. Charles, Dr. Geeta, and Dr. Jacob to please join us on the dais.
I think we don't have two of our expert panelists. Can I request Dr. Vikas Menon and Dr. Roshmi Gupta to kindly join the panelists on stage, and Dr. Morpia as well?
Meanwhile, we have the ISO 2024 app in case anyone has any questions related to the talks. Please feel free to ask it on the app itself. So welcome to the Eyelid and Orbital Tumors session. And we have lined up here some amazing back-to-back keynote lectures. To begin the session, we'd like to invite Dr. Kaustubh Mule, who is an ocular pathologist and needs no introduction. Can we have his intro?
We have an introductory video for Dr. Kaustubh.
Dr. Kaustubh Mule is a distinguished ophthalmic pathologist of unparalleled expertise, presently serving as senior consultant at the National Reporting Center for Ophthalmic Pathology, Center for Sight in Hyderabad, India. With a robust educational foundation in pathology, Dr. Mule has ascended to the pinnacle of his field and has established himself as a leading authority in ophthalmic pathology. His remarkable scholarly contributions have yielded an impressive 91 publications, garnering over 1,500 citations. Dr. Mule's outstanding achievements have been recognized with numerous coveted awards. Beyond his professional accomplishments, Dr. Mule is a professional triathlete, strength and conditioning coach, and certified rehab and mobility specialist, earning an impressive record of 6 Ironman finishes across 6 countries. His inspiring journey serves as a testament to his unwavering dedication to excellence in both his professional and personal pursuits, embodying a true embodiment of a polymath.
Thank you, Rolika. That was bombastic. Okay. Thank you, Dr. Santosh. Thank you, ISO, for having me over here. I hope you have had a taste of the Goan hospitality. Have you? Okay. So, did you get to see a lot of places around, taste some Goan cuisine? Yes? Okay. Does anyone want to tell me what this is? Have you all been here?
It's a church.
Oh. That's the Basilica of Bom Jesus. Now, there's a mythology associated with it. Now, you see this cross over here? It's a metal cross, so it rusts. Now, the mythology goes that the day this gets rusted and it falls off, that's going to signal the end of the world. That's what it says. Okay, did you get to eat this? Yes, bibinka. Did you get to go here? Very close by. This is a favorite of a lot of Indian movie directors. That's Dona Paula. It's just a walk across. I'm sure you would have seen this. Right? This is a very paintings which are very authentic to the Goan culture. Yes, very good. Okay. Now, today I'm going to start with this wonderful quote from Jean Piaget. It is truly said, science is always evolving. The science of today becomes the technology of tomorrow. Now, learning and transfer of knowledge has always existed amongst humans, right from ancient civilization. In the Babylonian or Sumerian era, or even in our Harappa and Mohenjo-daro times, people used clay tablets to store knowledge and transfer knowledge. Then came in the slates, where chalks were used to write. The teacher had to go to every student and write down a lesson. So what humans did was, they put down many slates together and created a blackboard. Now, these got modernized in the form of green boards and brown boards. I'm referring to the boards. The teachers were modernized by the cinema. Then came in the whiteboards with markers. Technology crept in the form of interactive boards. I'm sure a lot of you over here remember using overhead projectors and slide projectors for your presentations. Then the Gen Z started using PowerPoint presentations. And what is the Gen Alpha doing? Mobile learning. So we see how education has progressed from distance learning to e-learning and mobile learning. Similarly, the job of an ocular pathologist has evolved over several decades. Today, I'm going to take you through a small tour, a road down history to show you how pathology has evolved from morphology to molecular. I'm going to keep it very brief, very basic, so that a lot of you get to know what pathology is. Now, ophthalmic pathology started with the description of the gross anatomy of the human eye. Now, as concepts in histology and light microscopy developed, and alongside the development of the ophthalmoscope, clinico-pathological correlation became easier, and ophthalmic pathology further developed. Today, pathologists are at the center of multidisciplinary meetings, providing you vital information about diagnosis and prognosis, and even guiding treatments. Ophthalmic pathology has become a field from about just looking into slides to something that incorporates molecular genetics and genetic testing to bring precision medicine to cancer cure. Now, while ophthalmic pathology developed, so did other branches of medicine. With advances happening in imaging and clinical evaluation, diagnosis of tumors became easier even before the tumor was removed. Let's say, for example, look at this child. Now, if Dr. Feroz decides to enucleate, does she want to know from a pathologist that it's a retinoblastoma? Or let's just say, Lakshmi ma'am here wants to look at this elderly lady. Does she want me to tell her it's a sebaceous carcinoma? Probably not. They are looking for more information from a pathologist. Now, coming back to pathology, I mean, we pathologists are somehow obsessed about food. We correlate everything that we see to food. Squamous cell carcinoma has onion holes. A lacrimal gland tumor with a Swiss cheese appearance is an adenoid cystic carcinoma. This orbital tumor, a hemangioma, it has a honeycomb appearance. Lymphomas have a fleshy cut surface. Retinoblastoma has a fish flesh appearance. Amyloidosis, apple green birefringence. Coming back to traditional pathology. Now, we pathologists have also always relied on the use of formalin fixation and our pink and blue stain, imitoxylin and eosin, to give a diagnosis. Its ease of use, affordability, and accuracy make it easier to use, and it is unlikely that this process is going to be replaced by anything else in the near future. However, there are limitations. Now, given these limitations, it led to the development of ancillary techniques, the evolution, molecular diagnostics. So what are molecular diagnostics? These are tests which study genetic material in the human body. They detect biomarkers. Now, what are biomarkers? Biomarkers are measurable parameters of health and disease. For example, your ESR, your pulse rate, your heart rate, serum markers, anything for that matter. Similarly, there are biomarkers for cancer. They are found either in the cancer tissue or they are found in tissues or body fluids. Now, how does one detect these biomarkers, or how does one study these biomarkers? These tests are called molecular diagnostic tests. Now, immunohistochemistry was the first such test to evolve. The principle of immunohistochemistry is very simple. There's an antigen in or outside the cell. You add an antibody to it. If the antigen matches the antibody, there's an illumination, there's a glow, there's a color, and you call it positive or negative. Now, immunohistochemistry has been used for several decades to diagnose and differentiate tumors. Let's look at this elderly gentleman who presented with a swelling, eyelid swelling, and a mass in the orbit. Now, based on histopathology alone, that's light microscopy, I would probably, or any pathologist for the matter, would probably tell you it's a high-grade lymphoma. At max, he or she might tell you it's probably a high-grade lymphoma. But using immunohistochemistry, we could zero it down to being a DLBCL. Now, further, use of immunohistochemistry allows us to classify DLBCLs as GCB and ABC types. Now, one might say, what's the need to have this subclassification? Now, the GCB types of DLBCLs carry a better prognosis as compared to ABC ones. Further, MUM1 positivity and CD138 positivity in DLBCLs are associated with poor prognosis. I'm going to digress a little from eyelid and orbital tumors to this intraocular mass in this middle-aged gentleman, which was diagnosed to be an adenocarcinoma. Now, using immunohistochemistry, we could trace the primary back to the kidney. Now, immunohistochemistry using a panel of antibodies helps us pathologists to hunt down almost any primary in the human body. Immunohistochemistry has also been used to detect specific genetic alterations in orbital tumors. For example, STAT6 alterations in solitary fibrous tumor, loss of INI1 in ATRT or epithelioid sarcoma, TFE3 rearrangements in alveolar soft part sarcoma. Now, further, squamous cell carcinomas have been shown to express EGFRs. Now, considering this, EGFR inhibitors have been used to treat these patients with benefits. Thus, we see immunohistochemistry has now been used beyond diagnosis and differential diagnosis to guide management. Another example is a basal cell carcinoma. The detection of BRAF V600E mutations helps us use drugs like vemurafenib in these patients. Okay, before we get on to the next category, have you all got a chance to drink this? Yes, what is it? Sol curry. Now, all of you who aspire to lose weight, this is a very good for weight loss. Just don't keep drinking it all day. Okay, the next category of molecular diagnostic test is nucleic acid amplification. The commonest one is PCR. Now, let's look at this teen who presented with this very ugly looking tumor, an orbital tumor. Now, his light microscopy was very typical of an alveolar rhabdomyosarcoma. Immunohistochemistry helped me confirm it. Now, alveolar rhabdomyosarcoma is a very aggressive neoplasm. They are associated with mutations of the FKH FOXO gene with either PAX3 or PAX7. Now, again, why is this important? These can be detected using PCR or NGS. The importance lies in the fact that the ones that carry a PAX3 FOXO1 gene mutation have a poor prognosis and lower survival as compared to the ones with PAX7 fusions. This was a teen who presented with fever, proptosis, orbital mass, and that's how the tumor looked when it was taken out. Does anyone want to take a jump onto what it could be? Very classical. It's colorful, yes. Very green in color. What? Yes, Shefali? Very good. It's a chloroma. Are we done? Okay. How much time do we have? Okay, so this was AML. Now, FLT3 mutations are the commonest genetic alterations in a AML. Now, detection of these mutations using PCR or can help us introduce drugs like midostaurin or sorafenib. Also, AMLs associated with FLT3 mutations carry poor prognosis. Detection of NPM1 mutations in cases of AML, which lack FLT3 mutations, carry a better prognosis. Okay, now the last category of molecular diagnostic tests is cytogenetics, where we study the structure and the number of human chromosomes. It has been used rampantly in orbital lymphomas. IHC has also been used to detect cancer syndromes. For example, this is an elder lady with a sebaceous neoplasm. Now, presence of microsatellite stability in these patients prompts the clinician to look into the colon. What syndrome are we looking at? Mutor syndrome. Very good. Okay, now the most recent advance in molecular genetics is NGS. NGS has allowed rapid and cost-effective decoding of the human genome. Now, in clinical practice, it has been used to detect RB1 mutations in patients with retinoblastoma. Now, molecular genetics has allowed us to answer a lot of questions in cancer cure. The task that today's pathologist faces is very stark. Either he incorporates, learns, and includes all these learnings of molecular genetics into his day-to-day practice, or else they are going to be left as high-end clerks in this lab test loop. Harsh, but truth. Thank you. Apologies, Mitika, for shooting out the time.
Thank you so much, Dr. Costa. That was an amazing talk, and we learned the evolution and how important is it to have an amazing ocular pathologist along with us for diagnosis and management. And now we move on to, thank you so much. And now we move on to our next keynote lecture. She needs no introduction. Everything that we learned about Orbit is through her papers, and she's such an illustrious speaker as well. I invite Dr. Bita Ismaili to please talk about indications for immune checkpoint inhibitors therapy for eyelid, conjunctival, and orbital tumors. Thank you.
Is a multi-talented ophthalmologist and oncologist who has left an indelible mark on the field of ophthalmic plastic and reconstructive surgery. As a tenured professor of ophthalmology at the University of Texas, MD Anderson Cancer Center in Houston, Dr. Ismaili has spent over 2.5 decades leading a world-renowned orbital and adnexal oncology referral practice. Her clinical expertise encompasses the surgical treatment of orbital tumors, lacrimal gland carcinomas, eyelid cancers, and melanoma of the eyelid and conjunctiva. With over 320 peer-reviewed manuscripts, 16 invited articles, and numerous book chapters to her name, Dr. Bita Ismaili is a prolific scholar and educator who has taught extensively throughout the world. Beyond her numerous accolades and her professional accomplishments, Dr. Ismaili is a talented soprano, avid painter, and enthusiastic traveler whose passions and pursuits embody a true Renaissance spirit.
Thank you so much for that introduction. You guys are so creative with these and they're fun. And thank you, Santosh Feroz, for inviting me, the organizing committee. Thank you so much. And congratulations on a wonderful meeting. I've learned a lot. We've also enjoyed Goa. It's been quite a treat. Thank you very much. So indications for immune checkpoint inhibitors for eyelid, conjunctiva, and orbital tumors. I have combined my keynote with my paper presentation. So I have 16 minutes and I'm going to try to just try to cover the topic. I have no financial disclosures. And of course, throughout this meeting, we have heard about immune checkpoint inhibitors and how they are not terribly effective for uveal melanoma treatment, or they can only work for a very small proportion of patients with uveal melanoma. But for these three classes of cancers that we do see in the periocular region, for conjunctival melanomas, for periocular cutaneous melanomas, for squamous cell carcinomas of the conjunctiva, and squamous cancers with orbital invasion, and for Merkel cells. For these groups of cancers that really are in the adnexal and orbital carcinoma classification, this class of drugs is quite effective and they are very much in prime time. We are using them, they are effective, we see very nice outcomes. So I want to share that perspective with you and give you a bit of a history of how we have gotten to where we are with these particular indications. So I think everyone in the audience is familiar with this class of drugs. They are basically immune checkpoint inhibitors, refers to a class of drugs that now, I believe, last I checked, there are 24 drugs that are approved in the United States. They are, generally speaking, currently fall into three different categories: anti-PD-1, PD-L1 inhibitors, anti-CTLA-4, and more recently anti-LAG-3. And what they have in common is that they inhibit the checkpoint proteins. Checkpoint proteins are keeping the immune response in check. They're not allowing the host to reject the cancer cells, if you wish. And these class of drugs unleash that. They disinhibit that. So they unleash the immune response to cancer. And they have truly revolutionized cancer therapy throughout the world, and particularly in the US, because that is the first country that approved this class of drugs, and really for all solid tumors. Now, immune checkpoint inhibitors are used in various different indications for various different solid tumors. But of course, for our world of periocular world, orbital world, again, the indications would be for melanomas, for squamous cell carcinomas, for Merkel cell carcinomas, and for an occasional sebaceous carcinoma, not as much of an efficacy, but for some patients with sebaceous cancer, it can have efficacy. And a lot of the biomarkers that have been studied for efficacy has to do with how the tumor mutation burden is probably the most important biomarker. PD-L1 expression is important, but not as important, perhaps because there are cases where PD-L1 expression is not necessarily correlated with response. And DNA mismatch repair deficiency is thought to correlate with response to immune checkpoint inhibitors because, again, it correlates with tumor mutation burden. So let's start with melanomas. The first, I can say perhaps the first paper I'm aware of that kind of brings these class of drugs for use into our world of periocular was in 2017. We reported a few cases of metastatic cutaneous melanoma into the orbit. So these are orbital metastasis from a cutaneous source. And these patients did beautifully with immune checkpoint inhibitors. This was published with just a few cases. Then we kind of moved to treating patients with metastatic conjunctival melanoma with immune checkpoint inhibitors. And we were excited because it worked beautifully, and that was published in 2018. Then slowly, armed with that knowledge, we started to think about using it in patients who have locally advanced conjunctival melanoma. This patients have shown a lot and has been published. Interesting case of conjunctival melanoma that involves upper eyelid, lower eyelid, the entire ocular surface. So patients like this would historically have orbital exenteration because we really can't achieve local control in any other way. This patient was instead treated with single agent nivolumab, a PD-1 inhibitor, and you can see her photographic diary over time. After 4 months, we're beginning to see some resolution of pigment. We typically introduce topical chemotherapy after a few injections of immunotherapy, thinking that actually enhances the effect of immunotherapy. And then at 12 months, you have complete resolution of abnormal pigmentation with very few residual pigment remaining. That was biopsied, and it was just inflammatory macrophage and no melanoma remaining. I have 3 years of follow-up in this patient off treatment. She's still doing very well without local recurrence and no metastasis either. Another case, I shared this case with Claire Daniel at Moorfields. This is, it's her patient, but we kind of discussed this case a lot. And this patient was treated with bulbar conjunctival melanoma, bulbar tarsal conjunctival melanoma, very bulky disease with lung metastasis. He was treated with 2 drugs, Ipi and Nivo. And this is after 3 cycles, after 6 cycles, and the lung metastasis also resolved in this patient. These couple cases were published in 2020. Then what about now? What do we know about response rates? So people say, okay, so you show us these success stories, but overall, what can we tell about how often it works? In fact, throughout this meeting, I heard comments, maybe Sarah Lally shared with me that their experience is not as effective. Maybe it's like more like 10% of the times it responds. So it's because we don't really have large series that tells us how often can we expect response to treatment for conjunctival melanoma. So I sort of did a retrospective analysis of our cases, and the response rate is anywhere from 50 to 60%, depending on what indication. So this paper should come out in melanoma research. So if you are interested in the details, you can refer to that. But essentially, overall objective response rate was 8 out of 15 or 53%. These are small numbers, I realize that, but for conjunctival melanoma, which is a rare disease, it's still something to refer to for counseling patients and for judging whether you want to choose this approach. But interestingly, on patients that were getting it for local disease, for locally advanced indication, the response rate was even higher, 63%. So that still means that it doesn't work for all patients. So I really want to highlight that. So we still are in need of improved treatments for about 40% of patients with conjunctival melanoma that will not respond to immune checkpoint inhibitors. For cutaneous melanoma, this is, of course, where this class of drugs was first discovered. The efficacy of this drugs was first in indication for cutaneous melanoma. In the periocular region, this could be a patient like this. This is an 80-year-old man. He's a physician. He's very sophisticated. He has an invasive melanoma in the medial lower eyelid. At the time of presentation, we also found a palpable lymph node, which on FNA was metastasis. He does not have any distant metastasis. We elected to use neoadjuvant immune checkpoint inhibitor therapy. He got anti-LAG-3 plus nivolumab. And this is what happened to his eyelid mass. And importantly, his nodal metastasis also resolved. Now, he was given this neoadjuvant treatment because of the data that is coming out that, in fact, we get improved survival for patients like this with the use of neoadjuvant immunotherapy. Now, I did still operate that residual lesion. And in fact, that residual pigment is all inflammatory, no residual melanoma. And his lymph node metastasis also had completely responded to this treatment. So what about conjunctival squamous cell carcinomas? We know that this is a disease that's very amenable to surgery in the majority of cases, but we do have an occasional case that is T4, orbitally invasive, recurrent, and even metastatic to the lymph nodes. So I had a case like that. 92-year-old woman presents with this multilobular bulky conjunctival squamous cell carcinoma. Another case for just simple palpation, we find lymph nodes on lymph node metastasis, which on FNA is proven to be metastatic squamous cell carcinoma. Given her advanced age, given that this would require significant surgery for her, including maybe even an exenteration and parotidectomy, neck dissection, instead she was treated with single drug pembrolizumab. Now, important biomarkers in this particular case, she had a poorly differentiated squamous cell carcinoma. Tumor mutation burden was 75 mutations per megabase. That's a very high tumor mutation burden. So that speaks well for expected efficacy to immune checkpoint inhibitors. PD-L1 score was combined score of 5. Again, that's fairly high. So she was, after 2 cycles of pembro, you see complete melting of that conjunctival lesion as well as resolution of the lymph node metastasis. She is, of course, being carefully followed because we don't have long-term experience with this type of approach, but she has avoided all kinds of surgery so far. And the publication you can refer to for further details. So in my own experience, I would say not every patient with conjunctival squamous cell carcinoma responds. First of all, this would be only for locally advanced cases, only for cases that are metastatic, because the rest of the cases are curable with just simple surgery. Dr. Hakan Demirci has published on this topic in the journal Ophthalmology. Out of 5 cases, they showed 4 patients achieving objective response, and 1 patient had progressive disease. Hakan's here, and maybe he can comment on their experience. And of course, tumor mutation burden being one of our biomarkers, it is fairly high in conjunctival squamous cell carcinomas. And you can again refer to these publications that confirm that. And it's quite comparable to cutaneous squamous cell carcinoma. So another indication in my mind would be patients that present with squamous cell carcinoma of the face with perineural spread. So these are cases that are facial skin squamous cell carcinoma that gain access to large cranial nerves, typically V1, V2, and go into the orbit and into the base of the skull, into the cavernous sinus. These are not cases that are surgically curable. Historically, we would treat them with palliative radiation, high-dose radiation therapy with all of its side effects to the eye, as well as some palliative chemotherapy. But instead, today, I would say our go-to method should be immune checkpoint inhibitors when they are available in your countries and if it's affordable for the patient. So you can see in this particular patient, baseline, very bulky disease along V1. Then you see at 4 months of immune checkpoint inhibitor therapy. This time, in this case, he got cemiplimab, which is another PD-1 inhibitor. You see resolution of his ptosis. You see improvement of his extraocular motility. At 10 months, you have almost complete resolution of the mass. This patient will continue for 2 years unless he gets any side effects. Another interesting thing is that all of his scaly squamous cell carcinoma on the face also resolved. So if it's the patient that has large number of non-melanoma skin cancer on his face, that has also resolved. And so far completely avoided radiation therapy. Another case of very large bulky squamous cell carcinoma. Epicenter is the upper eyelid, but it's invading into the orbit. It's hard to know where it started. Is this a conjunctival origin? Is this a skin origin? We don't know. But cases like this, of course, would require radical surgery. Instead, this patient had chemo, in this case, chemotherapy combined with cemiplimab, which is a PD-1 inhibitor. You can see response to treatment, very dramatic response. After 2 cycles, then he went on to have surgery. This is short-term post-op appearance. I have 2.5 years of follow-up and he's doing well. Again, so far has avoided radiation therapy or exenteration. So immune checkpoint inhibitors for Merkel cell, I had a talk on this morning. But I think this is another really nice indication for immune checkpoint inhibitors because Merkel cell has a high risk of, it's aggressive, it has a high risk of metastasis. And although it's very radiosensitive, radiation in the upper eyelid is highly toxic to the cornea. So we expect an objective response rate of about 40% with immune checkpoint inhibitors. These are based on large-scale studies of Merkel cell carcinoma. I published 4 cases of Merkel cell of eyelid in ophthalmology recently, and we do see very positive responses in the eyelid area as well. I've used it in this case to shrink the tumor neoadjuvantly. So you see the large scaly lesion in the upper eyelid in figure A. After treatment with avelumab, which is again another PD-L1 inhibitor, you see shrinkage of the lesion, and then we can do less surgery. On the surgical specimen, we expect to see a lot of inflammation. So that patient had some residual carcinoma, but a lot of inflammation because of the immune response. Or in this case, where the lesion is complete, it's a much smaller lesion, and it's completely resolved after 2 cycles of pembrolizumab in this case. You can see the details in the ophthalmology paper. So we cannot leave this topic without talking about side effects. So immune checkpoint inhibitors, they essentially cause an autoimmune reaction. So you can get all kinds of inflammatory response. Most commonly, probably dermatitis, colitis in the form of diarrhea. That's really, really common. Pancreatitis, hepatitis, arthritis, myocarditis. All of these are potential side effects of immune checkpoint inhibitors. Fortunately, the overwhelming majority are grade 1, grade 2 in about 40 to 50% of the patients. Severe side effects, grade 3 side effects, are seen only in about 5% of the cases with PD-1, PD-L1 inhibitors. It's a higher percentage when we use ipilimumab, which is the CTLA-4 inhibitor drug in this class. Ocular side effects have been reported in the way of uveitis, extraocular muscle enlargement, myositis, orbital inflammatory syndrome, and optic neuritis. Again, overall, about 1% of the cases. And these side effects are usually managed with the use of steroids, with modification of the dosing and breaks from treatment, and they require vigilance. Fatal side effects have been reported in less than 1% of the cases. So in summary, immune checkpoint inhibitors are here to stay. They have revolutionized the treatment of solid tumors throughout the whole spectrum of solid tumors in the world of cancer treatment. And for our indications, unfortunately, they don't work very well for uveal melanoma, but they do well for conjunctival melanomas, for eyelid melanomas, and squamous cell carcinomas, as well as Merkel cell. So the indications really need to be for locally advanced or metastatic disease. So by no means am I suggesting that these are going to replace surgery. No, but the cases that I showed you, I think you see that these are advanced cases or metastatic cases. And the side effects are important, but usually mild, but they need to be mitigated. And the future directions really should center around which patients, can we predict which patients respond? And the biomarker studies, therefore, are very important for our field. I want to thank my medical oncology colleagues at MD Anderson, but I think in those early days after approval of these drugs, they were really the trailblazers, because when I would ask them to consider using them for our patients with periocular lesions, they were always, I always got a positive response, and that's really not a small matter. And they worked really hard to get insurance approval and also to hold hands with the patient while they went through these treatments with all of their potential side effects. Thank you very much.
Thank you so much, Dr. Peter, for that eye-opener talk. And we're moving from an era of just surgical excentrations to neoadjuvant chemos to immune checkpoint inhibitors. So that's amazing. And now we begin with the pre-paper sessions. And for the first paper, we'd like to invite Dr. Victoria Dye to please come up on the dais. And she'll be talking about computer-aided diagnosis of eyelid skin tumors using machine learning, application on images of eyelid skin lesions.
So I would like to begin with congratulating Santosh and Ferouz for the wonderful meeting. Really well organized, and everything was perfect. And I would like to thank the ASO members for the trust and the opportunity to be on the board that was active for 4 years. So thank you for that. And I'm going to present a joint study that was led by our plastic surgeons, and it's a joint study with Mount Sinai. And as we all know, malignant eyelid lesions could be benign or malignant, and the differentiation could sometimes be challenging. And it's very important to decide when and whether to biopsy the lesions. So we wanted to see if deep learning can actually automate the process of early detection of the eyelid lesions. So just recently, in January 2024, the FDA approved the Derma sensor, which is the first AI-proven tool with a non-invasive diagnosis of skin cancer at the point of testing. And we were quite surprised that it was approved for skin, but there was nothing on this kind for the eyelid. So the purpose of this study was to develop an optimized network based on machine learning to diagnose malignant skin lesions on the eyelid using machine learning methods. So it was a retrospective study where we utilized the eyelid lesion images from our Sheba Medical Center database. But to pre-train the system, we used a model and we actually utilized a big collection of photos from the International Skin Imaging Collaboration, ISIC 2019. This database is open for everyone and is free to use, and you have the information here, and I can give it to you later. So after we pre-trained the system, we then tested it on our database that contained multiple images per patient, aiming to classify the lesions to malignant and benign, and then actually to delineate the area that should be excised. So I'm not so good at the deep learning database materials, but this is the system that the Wise Computer guys used. It's called the EfficientNet B5 architecture. I cannot elaborate a lot about it, but you can read about it in the methods of the article. And as I said, they pre-trained the system with the database that contained more than 25,000 images, eyelid images. And then they actually tested it, trained, tested, and validated on our images. And this is more or less for us who do not understand the computer process, how it works. You present an image, something happens in between, and then the machine is telling you whether it's 0, which means benign, or 1, which means malignant. And totally, we tested 373 images. Of them, 186 were malignant, biopsy-proven malignant images. And we set up the system for sensitivity of 93.8% and specificity on 73.7%. And we can actually play with the sensitivity and specificity. We can actually get a better sensitivity, but then the specificity will drop. And as you can see here with the area under the curve, it was quite nice results with 0.91 indication. It's very good. And also the system gave us a heat map where we should excise, not only whether it is malignant or benign, but also what would be the borders of the excision. Sorry, I went the wrong way. So there is not much to discuss. What we wanted to achieve is that is something that would be machine-based, and there is no such things for eyelid skin so far. Only for FDA approved for skin, but not for eyelid skin. And we saw that we can actually get a good efficient advice from the machine. There are some limitations to this model right now. The sample size is not that big. As you saw, it's almost 400 images, but it's not enough to actually validate it on a large scale. So this is more or less proof of concept. And we were served as a single referral center.
Mine
Uh,
sorted.
Single referral center, and there is also the limitation of skin color. So to summarize what we did achieve, we achieved a new network that could actually predict or raise the suspicion of benign versus malignant lesion. It does not replace the physician. The physician should still be there and biopsy it. It is very, very good for rural area. It's very good to enhance the efficiency and maybe elevate the stress in the working centers. So what do we want to do to achieve in the future? We want to collaborate with as many centers possible, and the proof of concept is already published and you can download it from the QR. We already started to collaborate with MD Anderson and with one center in Delhi in India and one center in Nigeria. If you're interested to collaborate, please join us. And we are now laying the foundations for similar system for choroid and for conjunctival lesions. Thank you.
Thank you, Dr. Dai. And now we move on to our next speaker, Dr. Carl Moulon, and he will be talking about microcystic adenoid carcinoma case series and review of literature. Oh, that's Mulholland. Sorry, my bad.
No problem. So hello everyone, my name is Carl Mulholland. I'm currently based at the Tennant Institute of Ophthalmology in Glasgow, here today to present a case series of microcystic adnexal carcinoma of no relevant financial disclosures. So what is microcystic adnexal carcinoma? It's a rare sweat gland carcinoma. It most commonly affects the mid-face region. It's slow growing and indolent, but can have quite deep underlying invasion of underlying skeletal muscle and associated perineural invasion. And clinically, the lesions can extend beyond what you can see with your naked eye. They have a low risk of overall distant metastasis. So why is this specific condition a problem? Well, misdiagnosis is an issue. It's quite a rare clinical entity with most of the evidence we have available for it in case reports and small case series worldwide. It's varied clinical morphology. It can mimic other conditions and can be quite non-specific in its appearance. And there's challenges related to its histopathological diagnosis. And as mentioned, the disease itself can be quite insidious and locally aggressive, and specifically around the periorbital region with deeper invasion. The results can be quite devastating if not managed early. So within the Scottish Ocular Oncology Service, we report a case series of 5 patients with biopsy-proven microcystic adnexal carcinoma, slight preponderance for males with 4 out of our 5 patients and an average age of 69. The locations varied, eyebrow, upper lid and lower lid. And the duration was also variable, but was reasonably consistent with the literature, and that some of the presentations can be over a year, again, because of the slow growth and non-specific features. The literature would report 1 to 3 years would be an average presentation time. And here's some photographs of the patients that attended our clinic with the microcystic adnexal carcinoma, documenting again its clinical variance. So there's nodular type appearances with telangiectatic vessels, ill-defined skin thickenings with purr margins, scarring changes, and then if you look to the eyelid margins themselves, scarred changes with notching and eyelash loss, which again can mimic other conditions, for example, basal cell carcinomas. With regards to the histopathological diagnosis, it tends to have a bland appearance, features of eccrine and follicular differentiation with deep infiltration, ductal structures, and absence of mitotic figures, but it can quite often simulate other neoplasms such as infiltrative BCCs and syringiomas, particularly if the biopsy specimen is too superficial and not deep enough. And the literature would report that the histological misdiagnosis rates can be as high as 50%. Within our study, one of our patients had an initial correct biopsy diagnosis of microcystic adnexal carcinoma. One had a diagnosis of infiltrative BCC and the other 3 had an inconclusive result, although microcystic adnexal carcinoma was within the differential list. As mentioned, it's locally invasive, so we look to compare the results of our study with the literature. Reasonably comparable perineural invasion, 2 of our specimens. Again, the sample size is quite small. 2 out of our 5 cases actually had orbital involvement and went on to require exenteration, which is slightly higher than the literature would report. The other patients that didn't have orbital involvement underwent sequential 2-stage excision and reconstruction and have done quite well. So the management of this condition centers around good and complete surgical excision, whether by Mohs or slow Mohs with good paraffin margin control. It tends to be quite a chemo and radio resistant disease, although there are case reports and studies where they have been used as adjuvant treatments or perhaps alternative treatments in patients that have quite significant disease or unable to undergo more significant surgical intervention. This is an example of one of our patients who had an exenteration and then under the maxillofacial team had a radial free flap. Follow-up for these patients, again, is quite difficult. We don't have huge long-term follow-up data, but again, because of the slow growing and indolent nature of the disease, we tend to recommend following them up closely in case of any subtle recurrences that need to be managed. So to our knowledge, I think this is the largest case series of this condition, particularly in Europe. And MAC is quite a rare condition. But it's important if you have the clinical suspicion to get a good initial biopsy specimen that has appropriate size and depth and repeat the biopsy if the results are inconclusive or there's clinical suspicion. And gold standard is complete surgical excision with good margin control and then a consideration for longer term follow-up, again, because of its insidious nature. Thank you very much.
Thank you so much, Dr. Karl. And now we invite upon dais Dr. Natasha Van Poppelen, and she'll be talking about Mohs microscopic surgery in periocular tumors, a comparison between 2 decades.
Okay, good morning, everyone. First, I would like to thank the organizers for this excellent meeting. And I'm going to talk about the Mohs surgery here. I have nothing to disclose. So before I go to the Mohs surgery, I would like to make a comparison within the Mohs surgery between conventional surgery, the advantages. So if you have conventional surgery, you excise the tumor with a broad margin. And what you can see here with the arrow is indicated there's some tumor left. And because vertical slides are made, the sections there, they don't show any residual tumor in the tissue. So there's a false negative margin actually. And then with the Mohs surgery, you do more a cone-shaped excision with narrow margins, and then you squeeze the tissue together so you have the more superficial and the deeper tissue in one slide. So then you do horizontal sections, and you can see here that the tumor tissue in section A is detected. So you do an additional resection until all the tumor is left. There's no tumor left. So you can see it here. So one of the dermatologists explained it to me as a muffin. You squeeze the muffin all together, and then you have everything in one section. This is the way I remember it now, so I hope you will too from now on. So the advantages of this technique is that you have very small margins. You know that after a day of additional sections, additional resections, no tumor is left, and you can use different techniques to do the reconstruction. Because of this technique, you spare eyelid and lacrimal system, and you can use it for a variety of tumors. So we know that the incidence of skin cancer is increasing over the last decades. And the goal of this study was to compare the Mohs surgery in the beginning of this century, so the time period 2007 to 2009 and 2021 to 2023. We compared clinical and histopathological characteristics, and then also we take a look into the reconstruction after surgery. So this is an example of the periocular skin cancer we saw at our department and at the Mohs surgery program. This is the left eye, and you can see it mainly concerns the lower eyelid and the medial canthus. This is because of the sunlight exposure, of course. So then head on to the results. The most patients that were referred to our clinic were referred by dermatologists elsewhere in the country or from the Erasmus MC. So that was almost like 3/4 of all patients. The rest was referred by ophthalmologists and only a few percentage from plastic surgery or general practitioners. Then the last couple of years, we see that there's an increase in referrals from ophthalmologists and then also general practitioners and plastic surgery only like a few percentage. So this is the Netherlands. We are based in Rotterdam, which is in the southwest area. And what you can see here, that 2007, 2009, most referrals came from our region. However, the last couple of years, we've seen an increase in the referrals from all over the country. I think this has also something to do with the ophthalmologists that referred their patient to us, which were like colleagues of mine the last couple of years, and now they work all over the country and they refer patients to us. So the clinical characteristics. This was more or less the same between these two time periods. So male-female ratio was more or less the same with more females affected, but we saw an increase in mean age at diagnosis over the years. So we treated primary tumors, like those were referred to as like a primary resection, primary at the Mohs surgery program. However, we also had some heredical and recurrences. So then the histopathological characteristics. We mainly saw basal cell carcinoma in both groups. The basal cell carcinoma mainly comprised of the nodular type. However, we did see a difference in between the distribution of these tumor types between those two time periods. So in the second group, the later group, we saw an increase in sebaceous cell carcinoma, squamous cell carcinoma, and also other carcinoma, which involved, for example, Morbus Bowen. So then the reconstruction techniques. I won't go into much detail for this because of the lack of time, but we did see that we increased the more advanced surgical techniques that were used for reconstruction. So for example, if you excise more than 1/3 of the lower eyelid, you need some support system for the lower eyelid. So what you can do is use the tarsal plate of the upper eyelid, you suture this into the lower eyelids, and then you do a skin graft. You can do it either from the skin that is already at the lower eyelid, and if you have like a larger defect, for example, you can use the upper eyelids. Then you suture this all together, you leave it for like about 2 weeks, and after 2 weeks, you reopen the eyelids, and you have an upper and lower eyelids again. In the first time period, we did this technique, but only in 6 cases, and then later on, we see an increase. We did 27 over the last 3 years, which was a significant difference. So to conclude, we see an increase in the amount of patients referring to our Center for Mohs surgery at the ophthalmic dermatology program. The mean age of diagnosis is increasing, but we see mainly periocular basal cell carcinomas, which makes sense because that's the highest frequent skin cancer. We saw larger defects requiring more advanced techniques, and we think that the future perspective will be that there would be increasing demand for doctors that can do these techniques and to help this group of patients. Thank you for your attention.
Thank you so much, Dr. Natasha. And now we move on to the next speaker, Dr. Kelsey Andrea, and she'll be talking about cranial neuropathies due to perineural spread of squamous cell carcinoma, a multi-centric series and literature review.
Sorry about that. Thank you so much to the organizers for such a wonderful conference and for the opportunity to present our work. None of our financial disclosures are relevant to what I'll be discussing today. So as you heard in our delightful keynote lecture by Dr. Ismaili, squamous cell carcinoma is one of the carcinomas we deal with that has a propensity for perineural spread. And historically, when this occurs, it tends to be associated with a poor overall survival of only about 50% at 5 years. But in addition to overall survival, perineural spread can also negatively impact quality of life. And we see this in a number of different ways as ophthalmologists, with involvement of cranial nerve 5 and 7, resulting in a high risk of corneal decompensation, involvement of cranial nerve 3, 4, and 6, causing functional impairment due to diplopia. And spread via V1 through the orbit to the apex, in some instances causing a compressive optic neuropathy and decreased vision. Now, treatment of perineural spread has often involved resection of whatever residual primary lesion is available, plus or minus radiation and chemotherapy. But of course, immunotherapy has recently been added to the armamentarium for treating locally advanced cases. Immunotherapy appears to improve overall survival, but its impact on functional outcomes that affect quality of life are less clear. And so that was the purpose of this study, to look at patients who had cranial neuropathies from perineural spread of squamous cell carcinoma and to evaluate what their functional outcome was, specifically following treatment with immunotherapy. This was a multi-centered case series involving 6 academic institutions across North America. We included a total of 18 patients who had a mean age of 72 years, and almost 3/4 were male. As you can imagine, most of the primary tumors were quite advanced, with over 80% having an AJCC T-stage of 3 or greater. 83% of patients presented in the setting of recurrent disease, and the mean time from the initial diagnosis of squamous cell carcinoma to neuropathy due to perineural spread was just under 20 months. The diagnosis of perineural spread was confirmed on histopathology in just over half of the cases. It was typical for patients to have multiple cranial nerves involved, with 78% having more than one cranial neuropathy. And you can see here the depiction of the variety of cranial nerves that were involved. I want to zoom in on cranial nerve 5 and 7 because, again, as ophthalmologists, I think these are really critical to our patients, and 50% of patients had a combination of both. So to me, this means when you see a clinically obvious facial nerve palsy, it's really important to check V1 sensation to know whether their cornea is at particularly high risk of decompensating. And speaking of the facial nerve palsies, they tend to be severe when they're from perineural spread, with almost 2/3 of patients having House-Brackmann scores of greater than 5. Now, in terms of treatments, this was a clinically heterogeneous group across multiple institutions, and so a number of different treatments were employed, with about 44% of patients receiving a combination of at least 2 modalities. To focus in on the immunotherapy group, cemiplimab was used most commonly, followed by pembro, and 1 patient had received both at some point in their treatment course. Now, as we've seen with our other much larger studies, the response rate was really quite excellent, with 72% having at least partial response of the primary tumor mass. And 81% were alive at last follow-up, with a mean follow-up time just shy of 2 years. However, only 4 of our patients demonstrated significant functional improvement in their cranial neuropathy. 3 of these patients had an improvement, at least a partial improvement of sensory, and 1 patient had a partial motor improvement. In terms of clinical predictors that might increase the likelihood of functional improvement in cranial neuropathy, we found there was no significant correlation with overall tumor response. And out of interest, we looked at what the rate of functional improvement was in our non-immunotherapy group. These numbers are tiny, so it's not appropriate to compare them statistically, but roughly about 1/3 of patients in both groups had some improvement. And so because we felt limited by our small sample size, we turned to the literature and did a systematic review. We identified a total of 522 patients that had adequately described specific cranial neuropathies due to perineural spread. Similar to our findings, we found that it was typical for patients to have more than 1 cranial nerve involved, and the specific combination of 5 and 7 was fairly typical, just over 30% in the literature. Only 168 of those patients had functional outcomes following treatment documented. And again, you see relatively similar rates of functional improvement between 30 and 40%, potentially not significantly different between immunotherapy and traditional treatment groups. So in summary, I would say it's typical to have multiple cranial nerves involved when this disease progresses, and that a combination of 5 and 7 can be seen in 50% of cases, and really needs to highlight the importance of the ophthalmologist in managing the ocular surface and any, eyelid malpositions that are resulting from the severe 7th nerve palsy. And despite a relatively promising tumor response rate, functional improvement was less common. Though, of course, this might change with more data, longer follow-up, so the jury is not totally in. Thank you again for your time and attention. Shukriya.
Thank you so much, Dr. Andrea. And now I invite Dr. Shefali Chahar to please present her paper on how deep is deep an analysis of multi-level biopsy in orbital lesions.
Very good morning, everyone. My paper is titled How Deep is Deep? An Analysis of Multi-Level Incision Biopsy in Orbital Lesions. There's a wide range of structures that is present in the orbit, which can be the site of origin of tumors. Surgical orbital biopsy is the gold standard for accurate diagnosis, whether it is an excision biopsy or an incision biopsy. So literature states that 8 to 20% of the procured sample can give a wrong diagnosis, whether it's a non-specific diagnosis or a wrong diagnosis, mainly because of the unrepresentative sample that has been procured, because we know many lesions have non-uniform pathology. This can lead to delay in the initiation of management, which might make us do a repeat biopsy, which is a great financial burden for the patients. So when we have a clinico-radiological diagnosis in mind, the next questions to ask is how do we procure a sample for the most accurate diagnosis? How many layers should be biopsy? How deep should we go? And how deep is actually deep? So to answer these questions, we looked into the role of multi-level incision biopsy. How many layers? Well, to go from superficial, deep, and the deepest layer. How deep? Going through the epicenter of the lesion, which is radiologically defined, which can be radiologically defined. So when we look at the review of literature, not much literature exists which discusses the role of multi-layered biopsy for the procurement of accurate representative sample. And very few case series discuss pitfalls in diagnostic or diagnosing pitfalls in the incision biopsy and the pitfalls. So with this aim, we wanted to analyze the multi-level incision biopsy in orbital masses by retrospective interventional clinico-pathological case series. And we had a total of 169 cases which underwent a thorough clinico-radiological diagnosis and histopathological evaluation. The mean age in our sample group was 41.2 years and males predominated the series. And the most common presentation was proptosis. Imaging was done in all the cases, and the cases which underwent primary orbitotomy with incision biopsy were taken, and no repeat biopsy was needed to diagnose the lesions in our cases. So the flow of event was as follows. Orbitotomy was done. A cryoprobe was used for cryo-assisted multi-layered biopsy. Sample range was from 2 to 4, including the superficial, deep, and the deepest layer. And samples were subjected to histopathological evaluation and further IHC or microbiology as required. This is an intraoperative picture of a case which shows the procurement of the multi-layered biopsy using a cryoprobe. We had a total of 169 cases, out of which reactive were 101 and neoplastic were 68, out of which malignant were 61 and benign were 7 cases. So out of these 169 samples, superficial and deep confirmed the similar diagnosis in 154, but for 15 cases, superficial biopsy missed the diagnosis. And for these 15 cases, there was an alteration in the management for all these cases. 9 were reactive of these and 6 were neoplastic, out of which 5 were malignant too, including leiomyosarcoma, carcinoma ex pleomorphic adenoma, extranodal marginal zone lymphoma, and Ewing's class of tumors. So some representative and interesting cases from our study. This was a 42-year-old gentleman with a clinical radiological diagnosis of probably an inflammation, infection, or neoplasm. So when we did the superficial, when we examined the superficial layer of the biopsy, the sample that was taken, it showed fibrosis and mild patchy inflammation. Well, this would lead us to believe that it was an inflammatory case, and maybe we can go ahead with giving him steroids for this case. But when we go into the deeper layers, it showed granuloma with multinuclear giant cell, and the deepest layer showed fungi. So in fact, this was not a case of inflammation, but infective case, which was fungal granuloma. So you can imagine the implication of treating such a case with steroids, which can actually flare up his pathology. Another example of the 60-year-old gentleman whose superficial layered biopsy showed only benign reactive lymphoid hyperplasia, which could have been easily treated by only steroids, but the deeper layer showed CD3 and CD20 positivity, proving it to be ENMZL, and he went on to get radiation therapy too. Another example where the superficial layered biopsy showed only normal orbital soft tissue, but the deeper layer showed round cell tumors. In fact, in aggressive tumors, the deepest layer would only show necrotic tissue, hence the importance of multi-layer. Another example where the superficial layer showed dense fibrosis and inflammation, but the deeper layer showed vasculitis, proving it to be a case of Wegener's and which warranted a further systemic examination. So tabulating the results from our series, the sensitivity, specificity, positive predictive value and negative predictive value for a reactive sample was 100% in the deeper layer, and the difference in diagnosis of the difference layer was significant. Similarly, for neoplastic lesions too, it was 100% for deeper layer, and the difference was significant for the superficial and the deeper layer. So I would like to conclude by saying, to the best of our knowledge, no author speaks about the procurement of representative sample using a multi-layered approach. And as a protocol, orbital biopsies taken must be layered with samples obtained from representative areas of the lesion. Radiology can actually help estimate the epicenter of the lesion, and the sample should be taken beyond that epicenter of that lesion. And this can help decrease the need for a repeat biopsy, reducing the financial burden, delay in the time of diagnosis, and mismanagement of these cases. I thank my mentors for their constant support and guidance, and thank you so much for your kind attention.
Thank you so much, Dr. Shafali. And now we have Dr. Timothy Beckham. He's going to be talking about orbital biopsy in the United Kingdom, a 10-year review of a tertiary orbital service.
Good morning, and thank you to ISO for a brilliant meeting and the opportunity to present our 10-year review of orbital biopsy in Scotland. My name is Tim Beckman. I'm an ophthalmologist in Australia working with the Queensland Ocular Oncology Service. And today I represent the Scottish Ocular Oncology Service, and we present our work covering 10 years of orbital biopsy in Scotland. This provides a comprehensive review of the orbital service in Scotland, where I completed my fellowship. We reviewed clinical presentation, radiological, operative and histological details, as well as management and outcomes for all patients who underwent an orbital biopsy. We present results for 306 specimens from 281 patients. Average age was 52 years. Majority of patients presented with eyelid swelling or a palpable mass. Proptosis was common. Most patients had a painless presentation with no visual symptoms. Optic neuropathy was present in 12% of patients at presentation. Orbital imaging is important to guide differentials and management. Majority of lesions are extraconal in the anterior superlateral orbit. This has a direct correlation to the most common surgical approach, which was upper eyelid skin crease incision. 2% of patients underwent lateral orbitotomy. Most common diagnoses were lymphoproliferative and inflammatory, with both groups representing more than 20% of specimens each. This was followed by mesenchymal tumours, lacrimal gland tumours, and congenital lesions. Ocular adnexal lymphoma represents the most common specimen. The vast majority of these were low grade, with 40 cases of MALT lymphoma. 78% of patients underwent orbital radiotherapy. We present and report an 87% lymphoma survival rate for the duration of the study period. This 60-year-old lady presented with a slowly progressive, painless left proptosis. Incisional biopsy revealed sheets of lymphoid tissue, CD20 positive, and confirmation of low-grade B-cell lymphoma. She responded well to orbital radiotherapy. Orbital inflammation was identified in 65 specimens. This patient in our series had serological, radiological, and histological evidence of IgG4-related disease. Along with enlargement of the extraocular muscles, we see enlargement of the lacrimal glands and the infraorbital nerve. Incisional biopsy revealed a specimen with sheets of lymphoid cells, and IgG4-related disease was confirmed with immunohistochemical staining with IgG4 positive cells. This patient responded well to rituximab. The most common mesenchymal tumour was solitary fibrous tumour, with all 9 managed with excisional biopsy. A total of 7 cases of peripheral nerve sheath tumours were identified. This gentleman presented with hand movements vision and RAPD, and following excisional biopsy, this lesion represented the largest in our series with a maximal dimension of 60 millimetres. Here we see spindle-shaped cells within fibrous stroma, and STAT6 confirms solitary fibrous tumour. Vascular lesions represented 6.2% of specimens. This patient presented with an optic nerve compromise and choroidal folds due to a large intraconal mass. Lateral orbitotomy is a useful surgical approach for excisional biopsy of large posterior lesions causing optic neuropathy. Here we see good exposure for removal of a large cavernous hemangioma. Bone is replaced with plate and screws or silk sutures. This summarises the remaining cases in our series. 9 patients with pleomorphic adenoma were all managed with excisional biopsy, with no cases of recurrence or malignant transformation to date. Specimens representing orbital metastasis were low at 2.3%. This 26-year-old male presented with rapid onset painful proptosis. Specimen revealed a diffuse malignant infiltrate with sheets of malignant round cells. IHC shows myeloid differentiation and diagnosis of a myeloid sarcoma. Here we see an excellent response to DAGO chemotherapy as the orbital lesion melts away both clinically and radiologically. The most common surgical procedure performed was incisional biopsy for 61% of patients. Expediting an urgent biopsy is important in the setting of optic neuropathy or suspected malignancy. 38% of specimens were malignant, with the vast majority having an initial incisional biopsy. All procedures combined to achieve representative tissue for 98% of patients. Good visual acuity at presentation was typically maintained. The most common complication in our series was ptosis at 3.6%, with a total complication rate of 6%. Only 2 patients, less than 1%, displayed loss of vision as a result of orbital biopsy in our series. Both underwent lateral orbitotomy for large vascular tumours with intraconal extension causing compressive optic neuropathy. This is in keeping with large series in the literature. To our knowledge, this represents the largest documented series in the United Kingdom that specifically reviews orbital biopsy. Orbital biopsy is a safe procedure which has a high success of obtaining representative tissue. Lymphoma, inflammation, and mesenchymal tumours are the most common diagnosis. Malt lymphoma responds well to radiotherapy with a low recurrence rate and a high survival rate. Thank you.
Thank you, Dr. Timothy. And now we move on to our last speaker of the session, that is Dr. Satoru Kasi, and he's going to be talking to us about clinical features of the lacrimal gland pleomorphic adenoma, 2 referral center analysis in Hokkaido, Japan.
Good morning. My name is Satoru Kase from Hokkaido, northern part of Japan. Lacrimal gland pleomorphic adenoma, LGPA, accounts for 12 to 25% among orbital tumors, which is the most common lacrimal gland benign epithelial tumors. Histologically, LGPA comprises epithelial and stromal components, which may lead to recurrence and malignant transformation. Therefore, total en bloc resection is required. However, the resection for LGPA is conducted in a limited number of hospitals in Japan, so clinical pathological features have not been fully understood. The aim of this study was to evaluate the clinical features of primary LGPA. This was a 2-center retrospective observational study of 18 patients pathologically diagnosed with primary LGPA, who underwent tumor resection between 2010 and 2023. Medical records, including ophthalmological and imaging findings and post-operative course, were analyzed. And this is the busy slide, but the total patients are listed. The mean age at the time of initial examination was 56 years, with male to female ratio being almost equal. Initial symptoms were unilateral proptosis, followed by pressure sensation, asymptomatic eyelid swelling, ptosis, and decreased visual acuity. LogMAR best corrected visual acuity of the affected eye was 0.2. The intraocular pressure of the affected and healthy eyes were 20 millimeter mercury and 15 millimeter mercury, respectively. The difference in the degree of proptosis between the affected eye and the healthy eye was 4 millimeter by heterocular protrusion meter. One case had a history of breast cancer. 17 of 80 cases with orbital lacrimal gland origin underwent total tumor excision by anterior lateral orbitotomy. There was one case of suspicious recurrence 3 years after surgery. I'd like to show some representative case. The first case is a 44-year-old man. He suffered from the compressive sensation in the left eyelid. MRI on T2 displayed isointensity where the gadolinium enhancement revealed the enhancement. I favor use such machine cutting during the anterior lateral orbitotomy, and here is the video. And after the excision of the bone membrane, I used the electronic cutter of the frontal bone like this, and pick up the bone temporarily and keep in the moist condition. And then I use the cotton like this to separate the surrounding tissue from the tumor tissue. And I use the cryopexy to hold the tumor gently to separate the surrounding tissue as much as possible, and rotation very gently and smoothly. And finally, I excise the tumor from the orbit like this. And finally, I return the bone and suture the bone membrane. Histopathology, the tumor is covered with the unruptured fibrous capsule where tumor cells were made up of 2-layer epithelial cells with mucinous and cartilaginous stroma. The clinical outcome was that after 3 years, there was a nodule measuring around 10 millimeter at the supratemporal side of the lacrimal gland, suspicious of recurrence. So I am just observing the patient. The second case is a 63-year-old woman. She had a medical history of breast cancer. The doctors asked me to excise the tumor, so I decided to do the orbitotomy, and histopathology demonstrated the lacrimal gland pleomorphic adenoma, but not a metastatic tumor. Lacrimal gland metastasis from the breast cancer are extremely rare, and the growth rate and the findings of CT showing the heterogeneous and the bone invasion are different from our case. We have 3 cases with increased intraocular pressure. IOP elevation is rare in benign tumors of the lacrimal gland. The postoperative IOP in our 2 cases in which the affected eye had preoperative high IOP dropped to the same level as that in the normal eye after surgery, suggesting an effect of ocular compression due to increased periorbital tissue volume, which would be similar to thyroid-associated ophthalmopathy. In one case, postoperative long-term elevation of IOP due to chronic angle closure by the tumor compression could not be resolved even after tumor resection. Therefore, urgent tumor resection is recommended when IOP elevation was observed in patients with LGPA. In conclusion, patients with systemic malignancy may complicate LGPA, and patients with IOP elevation in LGPA. In such patients, total removal of the lacrimal gland tumor should be considered at the initial surgery. Thank you for your attention.
Thank you so much, Dr. Satoru. And while we collate the mark list, we have a couple of questions that we can take. We have the first question for Dr. Ismaili. Have you used ICI for treatment of recurrent and diffuse PAM with atypia in already treated patients with surgeries, previous surgeries, cryo, and topical therapy?
Sure. Yes, you can. Of course, the patients that I showed, they had large areas of PAM, but they also had an invasive component. So I think if for a patient who has PAM with severe atypia, meaning melanoma in situ practically, and such diffuse involvement that you are thinking orbital exenteration, yes, I would consider immune checkpoint inhibitors. And I mentioned it quickly, but I think it's really wise to use drugs like mitomycin C midway, because what it does is it almost like it makes the immune response wake up even more. In addition to its own effect, right? We know mitomycin C can work for PAM, but in a very determined way, we introduce additional insults, if you will, such as mitomycin C, to make the immunotherapy even more strong. But they didn't stay on mitomycin C the whole time, like the whole 12 months. We just did like one cycle of mitomycin C. I don't have large number of patients to show, but I think my general impression is that it helps if you add topical chemotherapy, similar to the idea that immune checkpoint inhibitors work better sometimes when you combine it with radiotherapy. You know, again, it's a way to increase the inflammatory response, tumor response.
And at what point would you add mitomycin C, like after initiation of ICM?
Oh, I don't think I have the magic number, but in my empiric experience, I've usually done it after at least 2 or 3 cycles of immunotherapy, just because a patient may not even tolerate treatment. There may be other reasons you stop treatment. So practically speaking, it's after a few cycles. If they're well tolerated, then you may want to introduce that. And it does seem to make a difference. I don't have a randomized arm without mitomycin C to tell you otherwise, but it seems like just based on a few cases, for the kind of case you're describing, diffuse involvement, like the one I shared, where your next step is exenteration, I think that it does help to combine the two.
That's interesting. Thank you. And there was a question whether do you still think there is a place for radiotherapy in case of lymph node involvement? Was this question for sebaceous gland carcinoma? I mean, squamous cell carcinoma? What was the question? I'm sorry. This is on the app. There's not much clarity on to whom is it addressed to. Yes, you can please go ahead with your questions.
Yeah. Thank you for the session.
Yep. Both very good questions. I've been passionate about extending access to Africa. It's after the last several years, I have been in negotiations with drug companies. I wish I could tell you I've been successful at getting them to engage and invest in African countries. Intravenous delivery is very complicated. As you know, it's not only is it costly, but it requires infrastructure to support it. So intralesional injections, I think, is what you're referring to. Yes, it's in the pipeline. It is in clinical trials, and I hope I can gain some traction again with the drug companies for ocular lesions. It's up to the drug companies to provide that to us. Well, it depends on your environment. I think I looked up whether it's available in India, and the answer is yes, it has been available in India since 2015. Cost, as you know, is very dependent on the locale, right? It's a business, right? So in India, it was something like, I converted it. I don't know your money all that well, but it was, I converted it to US dollars. I believe it's $2,000 per month, which in the United States would be a steal. I mean, that's like highly discounted cost. In the US, it's covered by insurance. So it's the patient doesn't pay. Yeah.
I'm sorry to interrupt. Maybe we can take one last question and then wrap up because we need to move on to the next.
In the interest of time, we probably take one last question.
Thank you. My question is to Dr. Beckman. I saw that you suture your lateral orbital tumors sometimes with the titanium plates and screws. Those patients, if it is benign, you will need to do a repeat imaging later on. So does it alter the images, and also I also used to close with those plates in the past, but I was told by my radiation oncologist not to do so if I am referring for the radiation, because they said it alters, it makes their dosimetry difficult. So what is your opinion on?
So we often use silk sutures just through a pilot hole, or we have used the plates as well. We've used those generally for vascular lesions, so that have required a lateral orbitotomy. So 2 cases in the series, large posterior where we needed better access, and we haven't had any issues with post-operative imaging with those plates.
For imaging, for radiation, does anyone have an idea whether it alters the dosimetry calculation?
We haven't had to radiate any cases.
Thank you.
You may want to point out to your radiation oncology colleague that titanium is in large plates is used in maxillectomy patients, and they're almost 100% of the times radiated with 66 gray. So I think the tiny little plate in the lateral orbit should not be a contraindication. They just might not be familiar with it. That's just my 2 cents. I've seen large titanium plates in radiated patients, and I think
Thank you
it's
so
fine.
much. I request the chair to announce the top 3 winners and hand over the medal to the topper. And I request all winners to come up on stage for a photograph.
Thank you, ISO. Thank you all for a wonderful session. The 3rd place goes to Carl Lund, microcystic adnexal carcinoma case series and reviewing literature. The 2nd place is to Victoria Vaishnaskaya, computer-aided diagnosis of eyelid skin tumors. And the 1st place to Dr. Kelsey Andrea, cranial neuropathies due to perineural spread of spinal cord.
I request the moderator and the panelists to join the chair and the winners for a photograph. Thank the speakers and the panelists. For our next paper session on orbital tumors, I request Dr. Bita Ismaili to chair the session. I also call upon Dr. Akshay Gopinath Nair as moderator, and our expert panelists, Dr. Mopia Goswami, Dr. Narendra Patidar, and Dr. Samiksha Tarepalli. I also request all the speakers to be seated in the front rows to save time, and I also request you to use the podiums alternately.
A warm welcome to the Orbital Tumors session. It's an honor to have the chair, Dr. Bita Ismaili, with us, and my expert panelists, Dr. Mopia, Dr. Narendra, and Dr. Samiksha. May I invite our first speaker, Dr. Mikhail Thagard, to speak on ocular adnexal T-cell lymphomas. A word for the next speakers to alternate. Be ready at the second dais on the other side.
So first, I would like to thank the esteemed chair and organizers for letting me present this paper on ocular adnexal T-cell lymphoma. I'm Mikkel. I'm from Hospital Sønderjylland in Denmark. I'm presenting on behalf of Professor Steffen Hegaard, who unfortunately was unable to attend this meeting at last minute. So ocular adnexal lymphomas are lymphomas located in the orbit and the conjunctiva, eyelid, the lacrimal gland, and the drainage system. And it is the most frequent cancer of the orbit, making up 15% of the malignant neoplasms. The lymphomas of the ocular adnexals are a very large heterogeneous group of tumors. They stem from B cells, T cells, or the natural killer cell origins. And the T cell lymphomas are very rare in the ocular adnexal, making up only 2% of the ocular adnexal lymphomas. So this was a retrospective multicenter study. I'd like to acknowledge the collaborators who gathered 42 patients from 5 international eye cancer centers. And the histopathological subtype distribution were that the largest groups were the peripheral T-cell lymphomas, not otherwise specified, which were 11 cases, the mucosis fungoides, which were 10 cases, and the extranodal natural killer and T-cell lymphomas, which were 9 cases. And then there were smaller numbers of other subtypes. The peripheral T-cell lymphomas, not otherwise specified, there were the 11 cases with a male predominance and a median age of 38 years. The orbital location was the most common, making up 91% in one eyelid, and it was almost equally distributed between localized and disseminated disease. Symptoms including swelling, tumor B symptoms in 27%, and the clinical findings were restricted eye movements, tumor, exophthalmos, and displacement. They were treated with chemotherapy for the large part, with or without radiotherapy. Radiotherapy alone or surgery, and the 1-year overall survival were 70%, and the 5-year prognosis in the literature is between 35 to 82%. Mucosis fungoides were 10 cases, also with a male predominance. The median age were older at 71 years, and all patients had eyelid involvement. All patients had diffuse skin involvement, which covered more than 10% of the body surface, and Sézary syndrome was seen in 2 patients. The symptoms included redness, ectropion, swelling, irritation, and tumor, and the clinical findings were ectropion, edema, erythema, and tumor. The 1-year overall survival was lower, it was 40% due to a high stage at the presentation in the eye region. The extranodal natural killer and T-cell lymphomas were 9 cases, also with a male predominance and a median age of 57 years. A large part was sinonasal, which had an orbital involvement, also involvement of the conjunctiva and the eyelid, and again, a very equally distributed between localized and disseminated disease. Their symptoms were sinonasal symptoms, decreased visual acuity, probably due to compression, swelling, redness, irritation, and B symptoms in 33%. And the clinical ocular findings were erythema and chemosis. They were treated with chemotherapy with or without radiotherapy in 89%, and radiotherapy alone in 11%, and none had surgery. Their 1-year overall survival was 56%, and the 3-year overall survival has been reported to be between 25 and 81% in the literature. Thank you very much.
Yeah, Dr. Shubha Prasad to speak on orbital lymphoma large case series.
Slides, please. Yeah. A very good morning. I would thank my mentor, Dr. Honavar, for giving me this opportunity to present our work at this prestigious meet. I shall be speaking to you on the orbital lymphoma, a retrospective analysis of our case series. What's already known is lymphoma being the most frequent neoplasm of the orbit, and that we know that lymphoproliferative lesions are a spectrum. This constitutes a majority of it. And most of these arise from the B cell with systemic involvement noted in 25% and surgical intervention, standalone EBRT or chemotherapy being the main arms of management in a case of a lymphoma. In our series, which was a retrospective interventional consecutive case series, we had 153 patients of biopsy-proven lymphoma, and the intervention involved for a well-localized lesion and excision biopsy, or for a diffuse lesion, it was a multi-level incision biopsy with or without external beam radiation or chemotherapy. And since we pathologically analyzed, it involved both simple H&E staining along with immunohistochemistry. What we saw on our demographical analysis was the incidence peaked in the 5th decade, while the gender predisposition showed a relatively higher male predominance, as was also noted in the study of the previous speaker. And the laterality of the tumor involving one of these orbits in between the two was in about 90% of the cases, with onset of features being chronic in about 80% of our series. So how did they exactly present to us? Please have a look at this particular slide, which shows a majority of them had a protrusion of the eyeball or the proptosis, coupled with presence of a palpable mass in about 50% of our cases. Topographical distribution showed that most of the masses were confined to the superior orbit, with an associated limitation on ocular motility noted in about 56% of the cases, with a majority of that involving an elevation deficit, say about 61% of our cases. Lacrimal gland involvement in about 26%, sinonasal involvement in about 15% of our cases, and CNS involvement noted in about 8.3% of our cases. The preoperative clinical diagnosis had a match to our histopathology in about 37% of our cases. And the intervention involved in a well-circumscribed lesion, a complete excision biopsy. And when the lesion was diffuse, we took a multi-level incision biopsy involving the epicenter of the lesion. What the histopathological analysis showed is right in front of you, with a majority of them belonging to the B cell type, of which the extranodal variety was a majority of this population. In front of your screens is one of those pictures which shows a florid proliferation of the lymphoid cells, which are also positive for the BCL2. The next in line is another subtype, that is a mantle cell lymphoma, staining positive with the cyclin D1, and the diffuse large B cell variety, which showed a CD20 positivity and a high Ki67 index. About 4 of our cases also belong to this T cell variety, constituting 1.2% of the entire population. And the arms of our management were either a complete excision biopsy with no further treatment alone in about 30% of the cases, while EBRT and a combination of EBRT and chemotherapy given in systemic cases, with the longest follow-up being for about 8.5 years. To see and look at the outcomes, we had a recurrence in about 5% of the cases, which are appropriately managed with systemic therapy and target therapy as and when appropriate, depending on the positivity on IHC, and an overall survival in about 94% with no lymphoma-related deaths and a death due to a secondary cause in about 6% of the cases. Let us now have a look at our selective outcomes. We present to you this young lady who had a swelling since 2 to 3 months with proptosis in the left eye. And this is status post-complete excision biopsy requiring no further treatment. On the next in the list is an elderly gentleman who showed a mass in the superior orbit, underwent excision biopsy, and this is what you see in front of your screens on histopathology. Status post-excision and EBRT at a 2-year follow-up showed no recurrence of mass. This is one such case which is treated with the standalone radiotherapy, showing good regression of the conjunctival component. And one such example of a use of standalone EBRT, which depends again on the histological subtype of the tumor and the grade, wherein it may range from about 26 to 46 centigrade. And another example where this underwent a complete excision biopsy of the conjunctival component while received EBRT and an intralesional for the orbital component of a target therapy like rituximab in the CD20 positivity cases. Following a systemic chemotherapy, this is the significant outcome we achieved. And another case which was diagnosed as some other malignancy elsewhere. And we went ahead with a multi-level incision biopsy, which was positive for DLBCL, had systemic involvement, received a target therapy plus a chemotherapy with the last systemic workup, like PET-CT in our case series, was negative on the last follow-up visit. With EBRT, we faced two complications. One was exposure keratopathy with microbial keratitis in about 2% of the cases, and radiation retinopathy noted in about one case. What we know from the literature and my references is this right in front of your screens. And to conclude, it is the most common frequent neoplasm of the orbit, with B cell origin being the most common cell. The extranodal and the follicular lymphoma, low grade, have better prognosis, and radiotherapy as monotherapy for low grade and for higher systemic grade chemotherapy gives good results. Thank you.
Thank you. I invite Dr. Mizuki Tagami to speak on gene expression in orbital lymphoma and orbital IgG4 related disease.
Hello everyone. I am Ms. Kitagami from Osaka, Japan. Orbital malt lymphoma and IgG4 rot are very similar clinically in imaging and histological examination. It is difficult to differentiate between two groups without histology. But there are currently very few reports examination their molecular biological origin. Can you see them? The top row is lymphoma. The bottom row is IgG4 rot. In the MRI image, it is almost impossible to tell them apart. In the HE image, fibrous component such as fibroblasts are somewhat prominent in the IgG4 rod in the bottom row, but they also look similar at first glance. In immunohistochemistry, monoclonal staining CD20 is observed lymphoma. IgG4 rot staining IgG4. The purpose is use a next generation sequence to investigate to molecular biological difference between the two similar disease. From 127 consecutive cases, 20 cases were selected for RNA sequence, and immunohistochemistry chemistry were performed. FFP sample sufficient cases. This is a slide showing the result. As you can see from the volcano plot and heat map on left, we found that over 500 genes were significantly expressed. In the tree diagram on the right, very interesting, IgG4 rot and MALT are clearly separated, but only MALT8 is under the IgG4 rot branch. This is next slide. Interestingly, the monoclonality of IgH bound by southern blot in MALT8. However, the IgG4 level is the in patient serum is high. IgG4 staining is relatively strong in immunohistochemistry. What does this mean? Our findings suggest that the two diseases might exist within a large spectrum. This is the next slide. The map on left a little bit complicated, but the involvement pattern recognition receptor for virus is suggested in the MALT network, in the bottom network. The upstream analysis revealed upstream gene is STING1. STING1 is molecular that originally recognition the DNA of virus and bacteria and released a response to cytokine. This one. This is the next. Based on these results, we performed immunohistochemistry for STING. Left is IgG4 rot, right orbital multiple lymphoma. Clearly, multiple lymphoma STING is strong. This one is a confocal microscopy labeled as STING1. STING1, left is IgG4 rot, right is orbital MALT. Left gene HPA is Golgi body marker. So you can see orbital MALT. In orbital MALT, co-staining in the Golgi appearance and STING1 in the cytoplasm. Conclusion, orbital multiple lymphoma and IgG4 rot can differentiate by two gene expression cluster. The STING pathway may play a more important role in orbital multiple lymphoma than orbital IgG4 rot. Thank you for your attention.
Thank you. May I now invite Dr. Banka Megha Ajay to speak on multimodal treatment of orbital rhabdomyocytes.
What does it take to save a child's eye and his life from a tumor as aggressive as rhabdomyosarcoma? Good morning, ladies and gentlemen. I'm Dr. Banka Megha Ajay, and today we unveil how the synergy of surgery, chemotherapy, and radiotherapy in orbital rhabdomyosarcoma not only saves lives, but preserves hope for a better future. As most of us are aware, rhabdomyosarcoma is the most common soft tissue sarcoma in children, comprising 4.5% of childhood cancers. It arises from rhabdomyoblasts, which are immature muscle cells that have the potential to develop into skeletal muscles. They have been categorized into 4 histopathological subtypes. Even though they are striated muscle tumors, it can occur in other tissues such as those in head, neck, trunk, and extremities. About 25 to 35% of head and neck RMS arises ophthalmic RMS. Shields et al. Described the clinical spectrum of primary ophthalmic RMS in the orbit, eyelid, conjunctiva, and the uveal tract. Historically, the survival of RMS was a dismal 30%. It was only after IRS trials and improved treatment regimens with surgery, chemotherapy, and radiation that a striking survival rate of 93% at 3 years was achieved without exenteration. We present to you our experience in managing orbital RMS. Our purpose was clear: to evaluate how cutting-edge techniques in surgery, chemotherapy, and radiotherapy have converged to enhance life and eye salvage outcomes. We did a retrospective analysis of the ocular oncology case files at Center for Sight, Hyderabad over the last 2 decades, and 60 patients with the diagnosis of primary orbital rhabdomyosarcoma were identified. The collected data included demographic details, clinical features following a thorough clinical examination, and investigation documentation. Our study included only HPE-confirmed orbital RMS cases who underwent multimodal treatment.
All patients were managed with surgery, followed by chemotherapy in the form of vincristine, actinomycin, cyclophosphamide, alternating with etoposide and ifosfamide for 3 cycles as per VAC-IE protocol for RMS, followed by stereotactic radiotherapy in the dose range of 4,500 to 5,500 centigrade, followed by another 6 cycles of chemotherapy. Outcome measures were assessed in terms of local tumor control, eye salvage, and systemic metastasis. Mean age of presentation in our study was found to be 7.8 years. The main presenting complaint was proptosis in 36 patients, followed by diminution of vision, pain, and ptosis. On examination, we noted extraocular motility restriction in 24 patients. The presentation was acute in 47% of the cases, subacute in 40%, and chronic in 13%. Majority of the orbital tumors were anterior or mid-orbital and posterior or diffuse in the remaining few. Primary surgery performed was multi-level incisional biopsy in 65% of the cases, debulking in 15% of the cases, and near total to total excision in 20%. Histopathology revealed 63% cases of embryonal RMS, 30% of alveolar RMS, 3% of anaplastic and botryoid variant each. We grouped these patients as per COG grouping and administered chemotherapy in dosages as per VAC-IE protocol for RMS. 4 of our cases which underwent exenteration as secondary surgery had negative margins and were given radiotherapy in the dose of 4,500 centigrade, while others which underwent only primary surgery were irradiated in the range of 5,000 to 5,500 centigrade. Adequate irradiation to the entire clinical target volume was ensured. After a mean follow-up of 48 months, we achieved resounding 97% local tumor control and 92% eye salvage as 4 cases underwent exenteration. Unfortunately, 3 patients succumbed to systemic metastasis. These success stories from our study strongly support the idea that a case of suspected orbital RMS should be primarily triaged based on the potential ocular morbidity arising from the procedure for an incisional biopsy, debulking, or excision, following which chemotherapy with VAC-IE protocol and adjuvant external beam radiotherapy must be mandatory components of the treatment protocol. Warrior et al. Reported an extremely rare case of late recurrence in orbital RMS, which showed complete remission. In our study, 11 cases showed recurrence and all of them had final regression, hence testifying for efficacy of multimodal treatment in recurrent orbital RMS as well. Eid et al. Reported a visual outcome of 612 in eyes treated with multimodal management, with cataract and keratopathy as the most common ocular complications. In our study, 60% of the patients maintained an optimal visual outcome in the range of 20/20 to 20/40, while the others were in the range of 20/40 to 22 or less than 200, 20/200. 2 to 3% of patients in our cohort had complications as enlisted, with exposure keratopathy and radiation retinopathy seen most commonly. On review of literature, for multimodal management, we found many case-based reports sharing their success. However, we filtered these 2 studies, which were most comparable to ours in terms of COG grouping of patients, multimodal management, and outcome measures. The mean age was comparable in the 3 studies, and the most common presenting feature of proptosis was consistent as well. The study by Varam et al. Is the interim report of the IRS Committee on Localized Orbital RMS, wherein they used vincristine, actinomycin, cyclophosphamide, and doxorubicin in 2 to 4 drug combinations, while Shields et al. And our study used VAC-IE. However, the overall survival rate was comparable. A tumor as deadly as RMS often comes with a better prognosis in the orbit than elsewhere in the body, giving the ocular oncologist a fair fighting chance and the power to save vision, eyes, and lives. Hence, but with great power comes great responsibility. Hence, we must use a robust multimodal treatment plan to manage these tumors, its recurrences, and metastasis responsibly. Behind every statistic is a child, a family, and a story of courage. Ladies and gentlemen, in the journey of managing orbital RMS, today with multimodal treatment, we are at the horizon where science meets hope. Thank you.
Thank you. May I invite Dr. Smita SK to present on the spectrum of SFT?
Good morning. I'm Dr. Smita Shambhu. I'll be talking on the spectrum of ocular and orbital solitary fibrous tumors. So I'll start off with this young 15-year-old girl who presented with a left axial proptosis. Rest of her ocular examination was within normal limits. She had a well-defined mass in the orbit, in the inferolateral orbit, involving both the intra as well as extracorneal aspect of the orbit. So I went ahead with a transconjunctival approach. And initially, this is after the periorbita was opened, it appeared innocuous. And as I proceeded with the blunt dissection, it started to bleed, and the blood bath continued for the next 2 hours. Pathology showed cellular spindle cells, tumor cells around the blood vessels with extravasated RBCs and STAT6 brown nuclear positivity. CD34 was also positive on IHC. So this was a case of orbital solitary fibrous tumors. It's considered quite rare, slow-growing fibroblastic tumors, and it's a mesenchymal in origin. The definition of these tumors is based on histopathology. They have to have these haphazardly arranged spindle cells, prominent staghorn-like vasculature, NAB2 STAT6 rearrangement. So this staghorn-like vasculature is basically the branching pattern of the vessels, which resembles a staghorn. So the most common site is the dura. The extrameningeal SFTs are commonly seen in the pleura and the trunk, and rarely in the head and neck region. There's no male to female predisposition, and it's commonly seen in the adults. Recently, WHO has classified hemangiopericytoma and giant cell angiofibroma into a common denomination of SFT. SFT has been characterized as an intermediate tumor with malignant potential, and in the orbit, it is known for its local recurrence. The purpose of this study is to show the multi-centered case series of orbital and conjunctival SFTs. We had 6 patients. The youngest was 15 years of age. I present the clinical presentation, radiological features, and pathology and management. We had 4 cases in the orbit and 2 in the conjunctiva. The common orbital presentation was proptosis and ptosis, no perception of light with disc pallor, and restriction of extraocular movements in 2 patients. The conjunctival mass, of course, presented with the conjunctival swelling. All patients underwent CT and MRI with contrast. However, the features were very non-specific. They were all well-defined masses with intra and extracorneal orbital mass, both anterior as well as posterior. 2 of the cases, we could see the mass extending into the orbital apex. MRI showed linear flow voids. All patients underwent excision biopsy. The surgical approaches was based on the location of the tumor. What was interesting was that almost all the cases, we encountered severe hemorrhage on table. So this led to partial resections. Patients with recurrence was advised radiation. Pathology remains the gold standard for the diagnosis of SFT. The morphology shows ovoid to fusiform spindle cells with indistinct cell borders. These are all haphazardly arranged cells, and hence the term patternless pattern. Dilated branching, hyalinized staghorn-like vasculature is very commonly seen. We do see collagenous stroma and myxoid changes with giant cell-rich variants also. IHC showed diffuse STAT6 nuclear staining in the SFT tumor cells in all our cases. This is highly sensitive and specific. All our cases also was positive for CD34. We did do a few negative stains for all our cases. Risk assessment in solitary fibrous tumor, this is based on Domiko's model, was done for all our cases. So this gives us an idea of the prognosis of our SFT. The risk factors taken into consideration was the age, tumor size, mitotic count, tumor necrosis. So our patients fell in the group of low to intermediate risk. To illustrate another patient who came to us with no perception of light, it was a case of recurrence. He had already had a diagnosis of SFT, and it was a huge recurrence into the orbital apex. We went ahead and excised the entire tumor, and he underwent radiation. As of follow-up of 4 years, he's tumor-free. The conjunctival lesions underwent complete excision. And as I said, giant cell angiofibroma pattern was seen in both our conjunctival cases and was diagnosed to be SFT based on the IHC STAT6 rearrangement. So the orbit cases, we had 4. 2 of them had no perception of light. 1 patient underwent radiation and has no recurrence. However, the second patient who also had recurrence is lost to follow-up. Rest of the patients had 6/6 vision. So what's something that we can do is the preoperative embolization of the feeder vessel. This was published in 22, wherein the feeder vessels were branches of the middle meningeal artery and the maxillary artery. And both the vessels were embolized using liquid embolizing agents. And the mass, that was a huge mass, was excised after 2 years. The other advances is the anti-angiogenic agents, which seems really promising considering the high expression rates of PDGFR and VEGFR in these tumors. 6-RNA targeting technology is also promising because it suppresses the expression of NAB2 STAT6 fusion transcripts. So to conclude, clinical and radiological features can be non-specific in SFT. NAB2 STAT6 gene fusion is highly sensitive and specific. The management and prognosis of SFT differs from its malignant mimics because it's highly vascular and local recurrence is extremely common. So complete en-bloc surgical resection is the gold standard. We need to have a long follow-up as they are known to recur even after 10 to 20 years. So I would like to thank all my co-authors. Thank you.
Thank you. May I invite Dr. Kirti Koka to present on intralesional bleomycin.
A very good morning, and thank you for giving me this opportunity. So I'm here to present my paper on a novel technique of ultrasound-guided intralesional bleomycin for orbital lymphangiomas. So we know that lymphangiomas are hematomatous malformations, and as per the International Society of Vascular Malformations, they are classified as slow flow to almost no flow malformations. So purely lymphatic generally are very rare, but generally what we have is a mixed veno-lymphatic. These lesions highly infiltrate the orbit, so making it very difficult to treat them. Earlier treatments used to be observation or surgery, whereas now it has moved to minimally invasive sclerosing agents. So we all know bleomycin, a cancer chemotherapeutic agent, has been widely proven to be efficacious for lymphangioma. But most often the injection is given blindly into the orbit, which carries a risk of injury to the globe, the optic nerve. Sometimes the drug is not delivered in the right place and hence the results are not so great. So what we tried to do was to evaluate the efficacy of giving it under ultrasound guidance. So we did a retrospective study over the last 8 years of all patients with orbital lymphangiomas, which was causing some kind of disfigurement or functional impairment to these patients. And we excluded patients who did not have a follow-up of more than 6 weeks. And anyone with any hypersensitivity to bleomycin was excluded from the study. So the dosage that we used was 0.25 to 0.5 international units per kg body weight. Bleomycin comes in a freeze-dried powder. And so what we did is we diluted it to sterile water in a 1:1 ratio along with 2% lignocaine. In children, we use general anesthesia, whereas in adults, topical anesthesia. Here you can see under ultrasound guidance, we are localizing the cyst cavity. Then a 5 cc syringe mounted on a 22 gauge needle is then introduced into the orbit in the particular quadrant under ultrasound guidance. The cyst is then aspirated, whereas sometimes in microcystic forms, you get a dry tap. Retaining the needle in the same position, the prepared bleomycin is then injected inside. And all the while, we have ultrasound guidance ensuring that the needle is well within the cyst cavity and not anywhere near the globe. So we know that the drug is being delivered in the right place. Post-injection, a pressure patch is applied for 6 hours. Patients are started on IV steroids for the day of admission, followed by oral steroids, tapering dose over 2 weeks to 4 weeks. We monitor the vision pupil on day 1 as well as day 2. And cold compressions are advised to the patient. Follow-up, we assess clinical and radiological assessment. So we had 56 patients over the 8 years duration with a mean age of 14.55 years. There was no gender predisposition. The main clinical features that they presented was sudden onset proptosis or an eyelid swelling resulting in ptosis. We did imaging either in the form of MRI or CT in all our patients. And we found the lesion to be purely extracorneal in 5, intracorneal in 9, whereas in 42, it was a mixture of extracorneal and intracorneal components. So the number of injections that patients needed ranged from 1 to 8, and we made sure that the time interval between injections was 4 weeks. And the mean cumulative dose of bleomycin given was 53.40 international units. So we assessed the improvement clinically as well as radiologically. Clinically, we found that there was significant improvement in 39, partial improvement in 16, whereas no improvement in only 1 patient. Radiological improvement was assessed either in the form of CT, MRI, or ultrasound, and we found significant improvement in 30, partial in 23, and no improvement in 3 patients. And this was over a mean follow-up of 10.88 months. So this is one of our patients. She's a 14-year-old girl with sudden onset proptosis. You can see the large lesion. She received 2 doses of injection bleomycin, and you can see on imaging she has significant improvement. This is a 4-year-old child with a large macrocystic component, just 1 dose of injection bleomycin under ultrasound guidance, and he is doing really well. This is a 2-year-old child who received 3 injections of injection bleomycin with significant improvement over a 14-month follow-up. And there's a 22-year-old male patient who also received 2 doses of injection bleomycin, and you can see that he also has a significant improvement. He has a small residue lesion, but however, since he is asymptomatic, we have kept him on follow-up. So in our study, we found complications like rebleed, which occurred in 2 patients. You can see the first set of pictures. There's a rebleed. We got an imaging done. The patient was managed with IV steroids followed by oral steroids and canthotomy, whereas the other patient, just IV oral steroids, there was significant improvement. Transient edema, ecchymosis was seen in 5 patients. Skin hyperpigmentation was seen, which is a known complication of bleomycin, was seen in 2 patients. And a superior sulcus deformity because of the long-standing lesion was seen in 3 patients. Nil recurrences were seen in any of our patients. So as we know, there are lots and lots of studies which have shown that bleomycin is very, very effective for treating lymphangiomas. But when we did a literature search for image guidance, most of the image-guided literature that we see is generally using cone beam CT and MRI along with fluoroscopic guidance to treat these lesions. But what happens in these settings? You need general anesthesia. But the advantage here is ultrasound guidance. So in slightly older patients and adults, you don't need general anesthesia. So when it comes to doing ultrasound, you don't need to have a multi-specialty hospital and hence no need of an intervention radiologist. And there's no exposure, unnecessary exposure to radiation every time you need to use image guidance. And the complications that we found were pretty transient, which could be easily treated. Thus, I conclude that ultrasound-guided bleomycin is a less invasive technique. You can monitor the position of the needle, so you're very sure about where you are, and you don't need to get into unnecessary complications. And also, you know that you have delivered the drug at the right place, and you can even certain times you can give the drug in a particular part of the cyst. The next time you can give it in a different part of the cyst. So ensuring that you have good regression of the lesion. Thank you.
In continuation with venolymphatic malformations, I'll invite Dr. Ankita Aishwarya Agarwal to speak on sirolimus for complex orbital venolymphatic malformations.
A very good morning, everyone. I'll be presenting our work on sirolimus, a ray of hope for complex orbital venolymphatic malformation cases. Well, venolymphatic malformation are benign hematomas that typically present during the first decade of life. They are called as complex if they are unresponsive to the previous treatment. There are various management options like surgical debulking. However, they are associated with higher recurrence. Sclerotherapy. They are less effective in microcystic variant and there is a higher risk of infection and even compartment syndrome. With medical therapy, sildenafil is more effective in macrocystic cases. Systemic steroids are generally not effective, and sirolimus is effective in both radiological and functional improvement. However, it's an off-label drug. Till now, there are no guidelines for managing complicated orbital venolymphatic malformation due to non-encapsulated and infiltrative nature. So sirolimus is a macrolide antibiotic which inhibits mTOR pathways. They are FDA approved for renal transplant and lymphangioliomyomatosis. However, it's used as an off-label drug in venolymphatic malformation since 2010. Based on this background, the purpose of our study was to evaluate the safety and efficacy of oral sirolimus in management of these cases. Our primary and secondary outcome measures are following. We did a prospective cohort study. After clinical radiological confirmation of these cases, the baseline lab test evaluation was done and the inclusion and exclusion criteria are following. The treatment regimen, So sirolimus was given orally at 0.05 milligram twice daily under the age of 18 years and 1 milligram twice daily for the adults. The target serum level was 5 to 15 nanogram, which was monitored at first month and then 3 monthly throughout the treatment period. All the patients have received sulfamethoxazole and trimethoprim for the prophylactic prevention of pneumocystis pneumonia. The response was divided into complete response, partial, and no response. Coming to the results, so we had 21 patients with a mean age of 12 years. Most of the patients have received intralesional bleomycin followed by STDs, surgical debulking, and combination. The most common presenting feature was proptosis, with a mean duration of symptoms ranging from 15 days to 1 year. The area of involvement in our case series, the most common was isolated orbit was seen in 29%, orbit and paranasal was seen in 24%, orbit and scalp was seen in 23%, orbit, paranasal, and oral cavity was seen in 3 cases, and orbit and brain involvement was seen in 2 cases. The mean duration of our treatment was 6.5 months, ranging from 3 to 12 months. At the end of the treatment period, the mean trough of serum level was 8 nanogram, which was within the normal limits. Coming to the outcomes, well, at a mean follow-up of 15 months, complete response was seen in 62% of the cases. Partial response was seen in 33% of the cases, where the asymptomatic ones were just follow-up, but the symptomatic, one patient was symptomatic, where the dose extension was given with sclerotherapy. No response was seen in one patient who was actually lost to follow-up and reinitiation was done. The improvement in visual acuity was clinically significant. The reduction in proptosis was also clinically significant. The adverse effects were mild and reversible. One case had recurrence due to loss to follow-up for 6 months. Let's have a look on a few case series. So this was a 9-year-old boy who has received bleomycin twice elsewhere and presented to us with decreased vision, chemosis, prolapsed conjunctiva, and isolated orbital involvement. With 3 months of treatment of sirolimus and 12 months of follow-up, the vision has improved to 6/6 part. There was residual proptosis of 1 millimeter and minimal intracorneal residual lesion was seen. This was another case of a 10-year-old girl who had received bleomycin elsewhere. She had presented with chemosis and diplopia with an isolated orbital involvement. With 4 months of treatment and 13 months of follow-up, the vision has improved and there was no diplopia. This was another case where 20-year-old lady has received both, has underwent debulking in surgery and bleomycin was given elsewhere. She presented to us with diplopia and decreased vision. Orbit and scalp both were involved. At 9 months of treatment and 18 months of follow-up, her vision has improved to 6/9 with mild inferior dystopia. This was an 8-year-old boy who has received multiple sclerotherapies. There was systemic involvement of lip and palate, and on MRI, orbit, maxillary sinus, and oral cavity were involved. At 12 months of treatment with sirolimus and 14 months of treatment, the vision has improved to 6/9 part with mild inferior dystopia. The palatal lesion has completely resolved with mild hypertrophy of the lip was still present. And MRI has shown that there was a residual superior orbital lesion was still there. If you look at various studies which has compared various treatment modalities for OVLMs, our study with sirolimus has a better response rate and lesser recurrence. If we compare the different case reports on sirolimus in complex OVLM cases, this is the largest series that we have present with a lesser duration of treatment and a better response. The limitations were small number of patients and lack of randomization. So to conclude, sirolimus is a promising and safe therapeutic option in complex orbital venolymphatic malformation cases. It is especially useful when surgical intervention carries a higher risk and when a conventional therapy has been proven to be ineffective. It provides a ray of hope for patients facing challenging orbital venolymphatic malformation cases. However, larger clinical trials are needed to clarify the optimal length of treatment, use as monotherapy, and long-term adverse effect. Thank you so much.
Thank you. May I now invite Dr. Lakshmi Mahesh to speak on orbital and associated cranial meningioma management.
Thank you, ISO, for this opportunity. Pronounced to the lotus feet of my Guru Bhagwan Baba. I would like to acknowledge all these practitioners who have helped me, radiologists, neurosurgeons, in the management of these patients. This was a patient who had a sheath meningioma, so I could remove the lesion in toto and she regained full vision. She was in her 4th decade. Not all patients are lucky as these. 30 years back, I was doing a lateral orbitotomy, a modified crinoline procedure, but I could not debulk the full lesion in many of the cases. Invariably, there was dip in vision. And the apical lesions, about 20 years back, I started with the help of neurosurgeons doing a frontozygomatic temporal approach. We could remove the lesion fully in toto, but it had its own risks, morbidity as well, because lengthy surgery, sometimes CSF leaks, etc. And again, vision could not be fully salvaged. So cranial approach also I felt was too lengthy and not the ideal for meningiomas. But 7 to 8 years back, this patient didn't want her surgery, but she had a dip of vision in four lines. She had all the classical features, periorbital puffiness. So I advised her to go for radiation, and she underwent gamma knife treatment. She improved very well. She has regained her full vision, and this is her visual fields. She's on a 7-year follow-up now. This was a patient with a plaque meningioma. She had a dip in vision of about 3 to 4 lines, and this is a visual fields to begin with on the left-hand side, and it beautifully improved. She has full vision now, and she just has a mild cataract where she needs to undergo cataract surgery. CyberKnife 25 gray in 5 fractions were given. And this you can see is her recent scans done this year. The tumor has also radified, and there's a little bit of pallor of the optic nerve, that's all. This was an unlucky patient again. I saw her sometime in 2007. She had a small lesion. She refused surgery. Then she had good vision. And she refused radiation as well. And she came back about 10 years later in 2017 with loss of vision. Again, she didn't want any treatment. And early this year, she had periorbital puffiness with pain, and she then realized her tumor was spreading posteriorly. So she underwent a rapid ARC, which is nothing but a form of IMRT, which beautifully confines to the tumor and treats the tumor. 24 gray in 27 fractions, and she's on a 4-month follow-up as of now. And even for patients with neurofibromatosis, the calm syndromes in this case, there's a little disc pallor. He has full vision. I've not yet advised him any treatment. And these with multiple tumors. This was a cementing fibroma of the cavernous sinus, a form of a very fibrosing meningioma only. And she has multiple meningiomas in addition to a few gliomas. And she has undergone CyberKnife, but she is not doing well because her case is pretty advanced. I think we should have treated her early on. So I am considering this now in future for gliomas and NF cases as well. This was a 43-year-old woman who came with mild propros. She was referred for thyroid eye disease, recent onset of hypothyroidism. She had all hirsute-like features due to hyperprolactinemia, diabetes of recent onset. And I generally do an MRI for all thyroid eye disease patients. And in addition to confirming thyroid eye disease, I did see this as well. A sphenopetroclival lesion, which was a meningioma. It was partially debulked and the rest was irradiated, and she is again maintaining very good vision and her fields. And this is a family friend. I'm here to convince her. She has a meningioma of the cavernous sinus, and she is yet to undergo treatment. Again, her main symptom is diplopia here, troublesome diplopia. So I think the future of meningioma management will only be radiation, and I'm planning to extend this for gliomas and neurofibromatosis cases as well. Thank you very much.
Thank you. Can I invite Dr. Sonam Poonam Nisar to speak on optic nerve sheath meningiomas, clinical profile?
Good morning, everyone. And at the outset, I'd like to thank the organizers at ISO. So, optic nerve sheath meningiomas are rare tumors of the central nervous system, and they account for about 2% of all orbital tumors. The aim of our study was to analyze the clinical profile, the radiological features, management outcomes amongst patients who were diagnosed radiologically with optic nerve sheath meningioma at a tertiary care center in South India. This is a retrospective observational case study over 9 years duration. Records of 39 patients who were radiologically diagnosed were reviewed. We excluded patients who had a follow-up of less than 12 months, associated ocular causes of optic neuropathy or any other retinal diseases, and with any missing data. So a total of 26 patients were included in the study with a mean age of 41 years. We noticed a main female preponderance, and a majority of them had unilateral involvement. The chief presenting complaints were deterioration of vision, followed by prominence of the eye, and the mean duration of symptoms was 24 months. 5 patients presented with no perception of light. 4 patients had best corrected visual acuity of less than 660 at presentation. 5 patients had deranged color vision at presentation, and about 73% patients presented with rapid afferent pupillary defect. Extraocular motility restriction was seen in 38% patients. Disc pallor at presentation was seen in 10, while 12 presented with disc edema and 4 just presented with a normal disc. Normal visual fields were seen in 5 patients, and constricted visual fields was the most common HVF finding in our study. 8 patients, we could not do HVF because of poor visual acuity. All patients underwent MRI with contrast and diffusion-weighted imaging. So we found about optic nerve sheath meningiomas to be intraorbital in 42% patients. Those extending up to the orbital apex had associated deterioration vision, and that was seen in 39% patients. And 19% patients had intracranial extension up to the cavernous sinus, as we saw in the previous study. Diffusion-weighted imaging showed restricted diffusion in 20, that is 76% of the eyes. Now, most common subtype seen radiologically was tubular, followed by fusiform and exophytic. So now, out of the 26 patients, 12 patients were just kept under observation because they had normal visual acuity, normal disc, and normal visual fields. About 11 patients underwent primary EBRT, that is 50 grays was given to them. And 3 patients who presented with no perception of light and exophytic optic nerve sheath meningiomas underwent surgical debulking, of which 1 patient had progression and required secondary EBRT. Of the 12 patients who we just kept under observation or refused for radiation during the primary sitting, we noticed progression in 8, that is 66% of them, and they also received secondary EBRT. The mean follow-up was 29 months. And if you see this, the visual acuity in the radiation group significantly improved at final follow-up. The one in the surgical group did not improve because most of them presented with no perception of light. And there was a deterioration in the visual acuity in the patients who were just observed, and then they received adjuvant radiation eventually. Visual field improvement was seen in most patients with who underwent radiation, and it was seen, and stable visual fields were seen in only 3 patients. Here you can see a patient who had at presentation disc edema, but look at the visual fields. It was absolutely normal, had 6/6 vision and normal color vision. We just decided to observe this patient because of the optic nerve function test, and the patient comes back to us after 3 years with this visual field and this disc. The patient underwent radiation and was doing well, and we were able to restore the vision to 6/9 after radiation. We also evaluated the radiological size, diffusion restriction, and the subtypes. It was very interesting to note that restricted diffusion actually is a very important tool in assessing whether probably the patient who were in the observation group might progress, might have further worsening of vision or not. So that was an interesting finding in our study. As you can see, this is a patient. You can see that this is a T2 weighted imaging of a patient in 2018. And post-radiation at 4 years follow-up, you can see that there is a reduction in the optic nerve sheath meningioma size. And look at the diffusion here. When you compare it with the normal nerve, you can actually see that there is a restriction. The diffusion restriction is actually reduced here. So that could be an important finding for us going forward in order to decide the treatment as well. Indications for surgery was basically with patients where eyes had no vision potential, disfiguring proptosis, and if at all there was a doubtful diagnosis. As you can see in this second patient, you can see that the optic nerve sheath meningioma is completely involving the paranasal sinus as well. So at last follow-up, we found that radiation retinopathy was seen in only 1 patient. About periorbital pain was seen in about 8% patients. Few of them had grade 2 skin changes after radiation, and 77% patients were fine without any significant side effects. So a review of literature showed similar results where we saw that there was a female preponderance. The dose of radiation was standard, that is 50 to 54 grays, about 1.8 grays to 2 grays given in each fraction. And that helped in vision stability as well as improving the vision. To conclude, limitations of a study was, yes, it is a retrospective study, so it's a short cohort. Optic nerve head OCT was not done because that would help us understand the ganglion cell loss as well. And it would be nice to have compared the ADC values on diffusion weighted imaging as well. To conclude, optic nerve sheath meningiomas in our study in the Indian subcontinent had a more unilateral prevalence with female preponderance. Deterioration of vision and proptosis was the most common presenting complaint. Tubular subtypes seem to be more symptomatic, and we can have them to give early intervention and they have a better outcome. Disc edema presentation also is associated with good responsive treatment. And diffusion weighted imaging could be a useful imaging tool to understand the progression of the disease as well. Thank you.
Thank you. May I now invite Dr. Charles Eberhardt to speak on optic pathway low-grade gliomas.
I'd like to thank the organizers for giving me a chance to speak today, and to everyone who's hung on here to the bitter end. I'm going to talk today about the role of microRNA in driving senescence in optic pathway gliomas. And most optic pathway gliomas, of course, are pilocytic astrocytomas. And it's been known for quite a while now that either fusions or mutations that activate BRAF are the most common molecular drivers of pilocytics. These are just a couple papers we had published on this years ago. With respect to BRAF, we know that in nevi, in the skin and conjunctiva, that while they proliferate for a while after BRAF is mutated, eventually a process called oncogene-induced senescence makes the nevi stop growing. And you can have the same thing happen in pilocytic astrocytomas, where after a time, there's upregulation of cell cycle checkpoint molecules like P16, P21, P27, that make the tumors arrest their growth, at least in a subset of cases. And again, this is just a paper where we had shown that can happen in pilocytic astrocytomas molecularly. And now this oncogene-induced senescence makes it really hard to develop culture models of these tumors. We tried all sorts of culture conditions for years, and the tumors would just stop growing in culture because of oncogene-induced senescence. Until a few years ago, when we tried this newer culture technique called CRC, don't have time to go into in detail, but it was designed specifically to prevent senescence of cells in culture. And we can look up the paper from a few years ago now. This really worked well, where the tumors grew very nicely in CRC media. And if you switch them to media containing serum, FBS stands for fetal bovine serum, they would stop growing and induce senescence markers. So now that we have a model system, we can ask the question, what kinds of mRNAs and microRNAs change with senescence in pilocytic astrocytomas, and might they be driving this process? So we took 5 of our cell line models shown here and put them in serum and induced senescence over a period of several days. They stopped proliferating. They induced cell cycle checkpoint molecules. They induced acidic beta-galactosidase, which turned the cells blue. And then we could sequence the cultures before and after senescence and ask what mRNAs and microRNAs were induced or suppressed after you force these cells into senescence. And here's an example of one that was downregulated across all 5 of these cultures over several days when you senesce the cells with serum. And here's an example of a microRNA that was upregulated over several days after you senesce the cells with serum. Now, we focused on 2 microRNAs that we thought might be functionally important, the microRNA 143, 145 cluster, as in other types of cancer, it had been associated with suppressing tumor growth when it was induced. And both of these microRNAs were induced with senescence in our cell culture models. And here's just a validation of our sequencing data showing indeed across multiple culture models, these microRNAs are induced on senescence. So these seem to be markers of senescence, but were they functionally important? Could they drive senescence? And so you can introduce into cultures these microRNAs exogenously, and now we're introducing them into cells that are in CRC media that are not going to be senescing spontaneously. And you can see, unlike the parental cells or cells that receive a control construct, when you put in either the 143 or the 145 microRNA, the cells stop growing. And the similar inhibitory growth curve is seen in a second cell line here on the right. Now, we did this in other models, non-CRC pediatric low-grade glioma models. It worked basically in all models except for those in which the brakes had been genetically deleted, where you'd lost P16 expression. Now, this slowing of growth was also associated with an induction of senescence markers. Here's just looking at P21 and P27 at the protein level. On the right, we also looked at lambda B1 and beta-galactosidase. All of these were induced by adding these two microRNAs, either one of them. And adding them was also associated with decreased proliferation using VRDU to measure it. And there was an induction of apoptosis, although it was non-significant. So in summary, oncogene-induced senescence, we think, is an important part of the biology of optic pathway gliomas. We know in some of these children, if you can keep them from having too much symptomatic progression over time, the tumors can stop growing on their own. We think we have new culture models that let us interrogate the role of both microRNAs and mRNAs. I didn't have time to talk about our mRNA data today that are associated with senescence. And we think we've identified at least two microRNAs that are functionally important in driving senescence. So why is that significant? Well, we could use these microRNAs, we can deliver them using nanoparticles or other delivery technologies into tumors and cause the tumors to stop growing. They could represent novel therapeutic approaches. There are newer senolytic drugs like Abataclax that actually kill senescent cells. And so you could potentially pair genetic therapies that drive cells into senescence with senolytic drugs that would then kill them. And we're actively investigating those possibilities. So thank you for your attention. I just want to acknowledge my colleague Eric Rabb and Ming Wan, who did all this work. Thank you very much.
Thank you. I now invite the last speaker of the session, Dr. Noha Mamdouh Mohammad Suleiman. Meanwhile, the other speakers in the session can also log on to the app. I can see there are a lot of questions that have been asked already. So if you could take time and enter the answers onto the app, that'll help in saving some time during the discussions.
Oh, there.
All right. Hello, everyone. Thank you so much for the invite. So I will be presenting part of my PhD project, which is the motility outcomes for the randomized control crossover clinical trial of 3D printed versus handmade artificial eyes. So the conventional or traditional method of making artificial eyes has been relatively the same for the past 50 years. It involves the use of invasive impression molding of the eye socket. It solely depends on the artesian skills of the ocularists, a very time-consuming process, exacerbating what's a very stressful time for patients. So I will be presenting a novel and new technology in manufacturing artificial eyes using fully digital end-to-end no-touch technique, while proving that the 3D artificial eyes are non-inferior to the handmade artificial eyes in terms of motility, which is the main outcome. As for the secondary outcome measures, such as volumetric analysis, adverse events, and patient-reported outcome measures, these were presented by Professor Mandeep Sagu as an e-poster here in this conference. So how did we manage to 3D print artificial eyes? So what we've done at that time, we've used an anterior segment OCT machine. We fitted that machine with a color calibrated camera and D50 light source. We've used that machine to scan the eye socket, and we've used the same machine to take a color image of the fellow eye. After that, we've used a specific software to to convert these scans and images to a 3D printable file. Later, we've used a medical grade 3D printer to manufacture 3D printed artificial eye. You can read here more about it. And this is one of our patients wearing the 3D printed artificial eye. So the clinical trial itself was statistically powered for 25 participants, but we've managed to get 28 participants to be randomized for each artificial eye type 1 and artificial eye type 2. And each participant wore each artificial eye type for 4 months, for which we've measured motility twice. Motility was assessed in different gaze and various directions, mainly adduction, abduction, infraduction, and supraduction. And then at the end, we've measured the total motility score, which is the sum of the measured motility in various gaze direction. So this image illustrates the process of measuring motility in various gaze direction using the standard rule measurement. So from January 2022 to July 2023, 28 patients were fitted with both artificial eye types. Motility was assessed for each artificial eye type. And as you can see from this table, the 3D, there is no statistically difference between each artificial eye type in terms of motility. So this box plot here illustrates the total motility score for each artificial eye type. Again, there is no statistical significant difference between each artificial eye types. So just to conclude, the 3D or digital artificial eyes demonstrated non-inferiority in terms of motility in comparison to the handmade artificial eye. So at the very end, I would like to thank my team members. So Professor Mandeep Sagu, he's not only my PhD supervisor, he's someone I look up to the most. So thank you so much, Prof, for all your help and guidance. Mr. Bell, without you, we couldn't finish the trial. And Dr. Stacy, your amazing statistical skill analysis skills, so thank you so much. And Professor Deck, thank you so much for all your guidance and support. Thank you.
Thank you, and I'd like to thank all the speakers for sticking to time. We've actually reached the end of the session with a good 15 to 20 minutes to discuss before moving on to the last session. I'm going to go with a couple of questions. A lot of them are for, I think, the bleomycin series. But before we go to the questions on the app, any of the members would like to please go up.
Wonderful session, Ihab from Egypt. I've been using bleomycin for the arteriovenous malformation, and I've been using them with the neuroradiologist that stick so many needles in the orbit. But for intracorneal lesion, anterior conjunctival lesion, I find it useful that we go do it directly with some openings, so mini surgical scars to get direct access to the lesion. And so the question would be, if we don't have the ultrasound guided because of the maybe sterilization issues, or if it fails, so opening and directly injecting would be an alternative or not?
Right. And Dr. Kirti, while you're answering that, there's also another question on the app asking for how did you maintain sterility of the ultrasound probe? So maybe you can answer both.
So the thing is, most often we are able to approach even the posterior ones. The ones which are really posterior, sometimes it's difficult to approach.
Intracorneal.
Intracorneal. So intracorneal, what we do is we go transconjunctival, we go subtenon, and then we reach the intracorneal space again under ultrasound guidance. So we know you're in the intracorneal lesion and then inject into it.
But if you have a spillover, would this induce an inflammation?
No, it doesn't cause any side effects. So most often the lesion is given, the injections are given blindly into the orbit. So you don't know whether you're really in the cyst. So sometimes it is given peri-lesional, but it still percolates into the lesion and still works.
Okay, but you're not against direct access to the lesion? And
no, we're not against. It's just that you can overcome that by giving a direct transcutaneous. You can even give a transconjunctival injection without opening. But if it is intracorneal, purely intracorneal, you might have to open up the subtenon space and then approach the needle. And regarding sterility, we do it under proper sterile conditions. We clean the entire eye with betadine, and obviously the ultrasound probe is also sterile, and it's all prepared in a sterile environment. The needle and everything is kept sterile, so that way we ensure sterility.
Thank you. So a question to the last talk, which was a great presentation. You found it to be non-inferior. Is it superior? What are the advantages? What's the cost of these prostheses? And will it, lots of questions, sorry. Will it suit a low-income setting country? Thanks.
Thank you so much for the question. As again, when this is a non-invasive study, so it was the agency to do that and in terms of the points, so far we've invested more than 2 million pounds in the project. For now, most of the hospital patients with disability conducted the trial, they can get the present artificial oil and at the same time having artificial oil is like 400. And in terms of having this technology in the lower and will find
May I ask you a question on the same paper? In addition to motility, of course, cosmetic satisfaction is another issue. And ophthalmos, just symmetry to the other side. Do you plan to study that in the future?
So we've already studied that, and Professor Sandeep Saduria, he has Boston,
I missed that, sorry. Yeah, okay. So it's comparable.
Yes.
So question for Team Moorfields again. So we know that with prostheses, you can get upper lid conjunctival squamous neoplasia development due to abrasions and constant inflammation with HPV ingress. It might be too early yet but have you found any complications of that nature, i.e. dysplasia being induced by the new technology compared to the previous technology?
There's a question about the rhabdomyosarcoma paper, but from the audience, this came to us via the app. What is your experience in adult onset recurrent embryonal rhabdomyosarcoma after all treatments, chemotherapy and radiation, those that are resistant to treatment? That's a question for our colleague on, Rhabda, yes.
In cases exactly, both in that is there,
Yeah, so second line chemotherapy and sometimes exenteration, right? There's a certain proportion that go on to progress. Thank you. There's a question for Dr. Takami on the IgG4 versus marginal zone lymphoma. They said the questioner says fabulous talk, Dr. Takami, so that's good. And then would you recommend giving a short course of radiation to patients where STING mutation is positive?
Thank you for your question. But my experience ongoing, not yet gene revealing test. So I recommend is not sure.
You're saying you're not certain?
Yeah.
Okay. I guess depends on if it's IgG4 disease, so treatments are either steroids or rituximab or
Yeah.
If not, then radiation. Yes, I mean, it's sort of like in that order.
Yeah, I recommend low concentration oral steroid is better. So some biological medicine is adapted to treat for sparing a steroid. But now I am going to choice it's the better in Japan.
So it's a choice between steroids and biologicals.
Yeah. Yeah. Thank you. So I have a question we had two very interesting presentations on meningiomas. I wanted to just ask a question from both of you as it comes up. Really two questions. One is, how often do you find yourself needing to do a biopsy to confirm the diagnosis? Because there will be a case that doesn't quite 100% radiologically follow the book. We have two speakers, so it's a question really for either of you. And yes, also the colleagues, yes, Dr. Lakshmi, yeah. So for both of you, that's the not one question that's worth some discussion. The second one is, well, I'll let you answer that one first. Yeah.
Yes, cases which do not follow the standard imaging patterns and doubt of your diagnosis and this is like
yeah, my question is how often does it in practice? What proportion of cases do you find yourself doing that? That's my question.
It's about 3 to 5%.
Yeah, so rarely. And the other speaker, you also had
almost a million.
So you find all of them to be fairly typical, right on. Yeah. If it's a classic case, of course, yeah. Yeah, occasionally it comes up where we feel forced. I try to avoid as well, but and then the second question is, again, so these are like controversies cited. There's not a straight answer, but I just wonder what you think. The timing of intervention. So like what visual acuity level, how much visual field loss, what findings on optic nerve examination is your threshold for recommending whether stereotactic radiation therapy or external beam? What are each of your thresholds, if you will, clinical thresholds?
Yeah, any early bookings inside is difficult to pick up, but early risk seizure trying to measure early pose, trying to period pain and pain, it's high level and several changes in the
What is your definition of big vision loss? That's what I'm putting you on the spot. There's not a magic number.
And the fundus and the visual. If I know that, I will go.
Is it 2040? Is it 2080? That's really what I'm asking. Of course, convert it to metric if you like. Yeah, so
I don't know that with the next. So, for us, any one of the topical function test which is going on, because as you saw in the study, there are cases very observed, and those cases eventually should. Also, another thing that we're looking at now is looking at differentiation. At least probably that peninsula is going to progress. I would not really like to give you one of
the progressive visual loss over time. And obviously, I'm asking the question because radiation therapy also has side effects. So you need to it's a balancing act. So some people, for example, say 2040 or worse. You know, I wondered if you have a magic number like that. Or visual field loss, of course, that's very objective.
Yeah, better than that.
Yeah, I don't think we have any other questions remaining from the app. And if we can tabulate the scores for.
So we have our winners of the session. So great. We start with our third place winner, Dr. Ankita Agarwal for thyroiditis. And I asked you to come to this stage. And then our second winner is Dr. Charles Eberhard, the sebaceous, the microRNA work for optic pathway gliomas. And our first place winner, although I lost the screen, is Kirti for the ultrasound guide of
Next, we have next videos. We had 6 video sessions, and we will be announcing the results of the top videos from each of these sessions. And for this, I request Dr. Vita Ismaili, Dr. Dan Roberts, Dr. Pastor Mode, Dr. Betsy, and Dr. Balaji, please come up on the side.
How are you? Good to see you. Gotta take the mask off.
So we have all video sessions. And we have request Dr. Balaji to announce the names and Dr. Vita Ismaili to give away the medals to talk. So we announce winners of all the video sessions and give away the medal to the top winner. And we'll be playing the video of all the toppers from each of the sections back to back, and that will be a judging.
Fantastic. So should I announce the names? All right. So to start with, we have ocular microvascular flow imaging, Dr. Aparna Raman Subramaniam. For the second video, are we waiting for them to come up on stage or should I? All right.
The winners will come up on stage for a quick photograph.
Dr. Aparna, if we have her in the hall. Aparna. So the second prize for the same category, and this is the uveal melanoma and other intraocular tumors, Dr. Scott Oliver. His video was titled Angiocatheter Assisted Forceps Biopsy for Transcameral Biopsy of Iris melanocytic lesions. Do we have Dr. Scott Oliver in the meeting hall? All right. So I'm just going to quickly go through the names. If you're around, please come up to the stage because I think we're going to save a lot of time that way. Dr. Deep Shekhar Das is third place for this. All right. Moving on to the second category, which is uveal melanomas and other intraocular tumors too. We have Dr. Andrea Yarovoy. Dr. Andre Yarovoy, I'm sorry. So his video was titled Anterior Uveal Melanoma with Extrascleral Growth of Different Extension. Dr. Andre? Yes, please.
Please come up and say this is for me.
Second place goes to Dr. Ruju Onadu. And the third place is Dr. Prapti. All right. So this Right. For the third category, which is eyelid tumors, ocular surface tumors, retinoblastoma, Dr. Ashwita Alva has won both the first and the second places. If Dr. Ashwita is around, please come up on stage. And Dr. Mritika has won the third place. Dr. Mritika. Just come up for a picture. Moving on to the next category, eyelid tumors, ocular surface tumors, Dr. Shefali, first place, Dr. Shirali Gokhru, second place, Dr. Feroz and Dr. Shefali combined third place. So, we have Dr. Rolika Bansal first place, Dr. Ananya second place, Dr. Chavi Gupta third place. Dr. Ananya, come up on stage for a picture. Dr. Chavi. For the last category, we're just going to wait for Dr. Ananya to come up. Dr. Vijita first place, Dr. Arun Singh second place, and Dr. Subha third place. So if everyone could just come to the stage for picture.
Hi, I'm Aparna Ramasubramanian, and we would like to discuss our experience with ocular microvascular flow imaging. I'm a consultant for Day One Biopharmaceuticals for Vorafenib that makes a medication for glioma, and it has no conflicts of interest with the current drug. The first application of diagnostic ultrasound in the eye was reported in 1956, and since then it has become a routine modality for imaging multiple ocular conditions, including anterior and posterior segment tumors. Color Doppler imaging was then used, and it is particularly useful for persistent fetal vasculature. The color Doppler imaging has not been used extensively in retinoblastoma, but the difficulty inherent with color Doppler imaging is that tumor vasculature are slow flow systems that cannot be well visualized with color Doppler. Leading on to the microvascular flow imaging, it is a recent development in non-invasive ultrasound technology. It measures the blood flow without the use of contrast agents. It uses a special novel cluster suppression algorithm, and it separates the slow flow signals from the tissue motion artifacts. It can measure vessels as small as 0.1 millimeters and flow velocities as low as 1 centimeter per second. The imaging in our study was done on a Philips system, the EPIC Elite system, and these are the different probes that we use for the microvascular flow imaging. The microvascular flow imaging has been used extensively for hepatocellular carcinomas, and it is best suited for tumors that are less than 4 centimeters in depth. And that is why it is ideal for ocular imaging. So in our preliminary study, we evaluated 20 eyes totally. There were 13 eyes with retinoblastoma, 6 eyes with persistent fetal vasculature, and 1 child referred with suspected medullopithelium. And this is what the normal MFI looks like. You can see the ultrasound image on the left and the MFI. You can choose the color pattern you want to use. And then it shows a flow in the retinal choroid, which is more prominent in the posterior pole, and anteriorly, you don't see much flow. In retinoblastoma, there are 3 different vascular characteristics that we have described in MFI. The basket vasculature, the tumor feeder vessel, and the tumor bed vasculature. And this is what a basket vasculature looks like. This was a description that was used for other tumors. So we use the same nomenclature for the MFI of retinoblastoma, where you have the tumor that surrounds and then fills the entire center of the tumor with the MFI signal. And this is what a tumor feeder vessel looks like. You see a really big feeder vessel that is very nicely seen on the MFI. Even on fluorescein angiogram, it's not as clearly seen as on MFI. And this is the tumor bed vascularity. Right under where the tumor is seen, you see a really hyper-reflective area of the MFI image. So in our 13 eyes with retinoblastoma, basket vasculature was seen in 46%, tumor feeder vessel was seen in 61%, and tumor bed vascularity was seen in 77%. At least 1 MFI characteristic was seen in all the eyes, and all 3 characteristics of basket vasculature, tumor feeder vessel, and tumor bed vascularity was seen in 23%. So it is increasingly known that tumors are now complex microenvironments, and bidirectional dynamic interaction occurs between the vascular and the immune components. So maybe MFI will help us understand these microenvironments by better understanding the vascular supply inherent within the tumor. We currently do not have a very good parameter to determine which eyes have globe salvage after intraarterial chemotherapy, because it is so dependent on the vascular supply of the tumor. We have not been able to correlate the MFI with the intraarterial response because of the number of patients so far, but we are hoping in future we can use this technique to maybe predict which are the eyes that are more likely to respond to intraarterial chemotherapy. Next, moving on to persistent fetal vasculature, Hu et al. Described 4 different categories of persistent fetal vasculature, the I type, which is type 1, the Y type, which is type 2, the inverted Y type, which is type 3, and the X type, which is the type 4. This is what a persistent fetal vasculature looks like on MFI imaging. So you really see the extensive vascular pattern. Even the small fibrillary vessels can be very nicely seen on the MFI. There are a couple of other images where the patients that were originally seen on ultrasound and even diagnosed with color Doppler, the classification of the tumor actually changed after we did the MFI. In this, you feel it is a narrow stalk, but when you do the MFI imaging, you realize it's actually a Y type of persistent fetal vasculature. And this is really important because it is modifying the PFP classification, which has implications on the final surgical approach. Lastly, this is our patient with a presumed medulloepithelioma, and this is the anterior MFI imaging. Again, anteriorly, you don't see much MFI signal normally, but if there is a tumor, then you can see the inherent blood supply in the tumor with MFI imaging. This patient underwent excision, and on histopathology, it was a perivascular endothelioid cell tumor or a PCOMA. This is our very preliminary analysis. We had a patient with family history of retinoblastoma where we were doing fetal ultrasounds and we diagnosed a very small tumor. And even on the fetal ultrasound, when we used the MFI probe, we were able to see the tumor bed vascularity with the MFI imaging. So it could potentially be used when you're unclear if there is tumor bed vascularity. And this is the same patient on follow-up, had a larger tumor, then was delivered at 37 weeks. And this is the fundus photo of the tumor post-delivery. So in conclusion, microvascular flow imaging is a very novel ultrasound technique. It does not require any contrast agents, and it is ideally suited for ocular imaging because of the depth of the image. In retinoblastoma, it reliably shows the microcirculation, and it could potentially be used to predict which tumors are going to respond to chemotherapy. With respect to persistent fetal vasculature, it is very useful for diagnosis, for classification of the PFV, and potentially to alter the surgical approach based on the type of PFV. We have used it for anterior segment tumors also, but in future, we could potentially use it for other ocular conditions, like even persistent fetal vasculature, familial exudative vitreoretinopathy, retinopathy of prematurity, etc. Thank you very much for your attention.
My name is Andrei Yarovoy. I'm from Moscow, Russia, and I will present the main stages of full-thickness eyeball resection for anterior uveal melanoma with extrascleral growth of different extension and donal scleral patch pattern. As a rule, extraocular extension of uveal melanoma is an indication to enucleation, but in selected cases, it is possible to save the eye. The first case, 48-year-old woman with iridocellular parietal melanoma was treated previously with ruthenium brachytherapy with subsequent extrascleral tumor growth. It was decided to fulfill a full-thickness eyeball resection. Histological examination revealed epithelioid cell uveal melanoma with extrascleral growth. The second case is a 63-year-old patient with extrascleral growth after ruthenium brachytherapy. He refused to enucleate the eye. In this case, we used a flexible silver wire to transfer an oval shape of resected sclera to a donor one. This is the treated eye 1 month after surgery. This 40-year-old woman with iridocellular choroidal melanoma with episcleral tumor growth had 1.0 vision. Full thickness eyelid resection was proposed as an alternative to amphibiation. This case of irregular shape of the sclera to be excised, we use semi-transparent latex film to mark a donor graft with the same shape. Histological examination revealed spindle cell uveal melanoma with extrascleral growth. This 15-year-old boy was referred to us with iridocellular choroidal tumor after an informative fine needle aspiration biopsy elsewhere, with recommendation to enucleate the eye. There was a pigmented spot at the scleral biopsy site and the suspicion of tumor seeding within biopsy scleral channel. Histological examination showed primary subtotal necrosis of uveal melanoma. The eyeball and high vision were retained. Our final case is a 17-year-old boy with cerebroidal melanoma with scleral stain and episcleral tumor growth after brachytherapy. The parents refused to enucleate the eye. In order to cut out a donor scleral graft of regular shape to match the resected patient's sclera, we used a transparent film and marked the borders of the scleral patch. Uveal melanoma with subtotal necrosis was revealed, and this is the eye 6 months after surgery. Thank you for attention.
depth of a child's eye, a silent threat looms. Retinoblastoma, the most common intraocular malignancy that may steal sight and life. But in this battle, innovation shines bright. Over the past 3 decades, evolving treatments have rewritten the story, preserving life, vision, and eyes free from the scars of external brain radiation or enucleation. In 1954, Allegren Rees initiated intraarterial chemotherapy for retinoblastoma by injecting triphenylmelamine into the internal carotid artery. In 1998, Inomata and Kaneko from Japan pioneered an alternative approach, selective ophthalmic artery infusion with the help of balloon catheter and injected melphalan. In 2006, Abramson and Gobin refined the technique into super selective triple drug eyes with direct ophthalmic artery infusion. Let's first understand the anatomy of ophthalmic artery. It's the first intracranial branch of the internal carotid artery originating from the sixth segment on medial side of anterior clinoid process. It traverses a short intracranial course before piercing the dura, entering the optic canal just lateral to the optic nerve. Within the optic canal, it branches into a complex pattern to vascularize the eyeball and surrounding periophthalmic tissues. The diameter of the ophthalmic artery typically ranges from 0.7 to 1.8 mm and gives rise to several branches. In certain cases where catheterization is challenging, alternative routes are used. Notably, in about 7% of the individuals, ophthalmic artery originates from the middle meningeal artery, making it a viable option for catheterization. Procedure is performed under general anesthesia in a well-equipped catheterization laboratory or interventional suite. For the procedure, precise and meticulous marking of both treatment eye and the right thigh where femoral artery catheterization is planned. The femoral artery on the ipsilateral side is accessed under aseptic precautions with ultrasound guidance using a 5 French pediatric arterial sheath. The catheter is carefully guided under fluoroscopy up to the common iliac artery, through the aortic arch, into the carotid artery, and then to the internal carotid artery, finally reaching the ostium of ophthalmic artery. Serial angiograms are performed to evaluate the cerebral vasculature and to identify the angioanatomy with special attention to the choroidal blush in the angiogram. After confirming the placement of the catheter at the ophthalmic artery ostium through an angiogram, chemotherapeutic drugs are diluted in 30 cc of normal saline and infused slowly over 30 minutes at a rate of 1 centimeter cube per minute. This is delivered in a pulsatile, non-laminated fashion. Melphalan, topotecan, and carboplatin are used at a dose depending on the patient's age, severity, and extent of the disease. A repeat angiogram is performed after the procedure to rule out any thromboembolic event. After the procedure, the microcatheter are slowly removed and hemostasis of the femoral artery is achieved by a compressive bandage. After IAC, patients are evaluated every 3 to 4 weeks. Typically, 3 monthly sessions are given to maximize tumoricidal effects while minimizing the toxicity. If complete tumor regression is achieved, further IAC is discontinued. Intraarterial chemotherapy is given as the first line of management in unilateral retinoblastomas in Group B, Group C, Group D, and Group E. They may also be given as tandem IAC for bilateral retinoblastomas. However, it's avoided if the better eye has visual potential. It's given as a second line of management after prior treatment failure in recurrent tumors, subretinal seeds, or both. Bridge IAC refers to the treatment approach where therapy is initiated after intravenous chemotherapy, particularly in neonates. Rescue IAC involves the re-administration of IAC following an initial course of it typically in cases of recurrent tumors, subretinal seeds, or vitreous seeds. Intraarterial chemotherapy is relatively contraindicated in eyes with clinically high risk factors, radiological evidence of optic nerve extension, scleral extension, or intracranial extension, in extraocular or orbital extension of retinoblastomas, in tumors amenable to focal TTT, cryotherapy, or intravitreal chemotherapy. Compared to IEC delivers chemotherapy directly into the eye, providing 10 times more of the drug. This approach significantly increases tumor exposure while reducing systemic side effects. For group B and C eyes, it achieves an eye salvage rate of almost 95 to 100%. IAC shows notable advantages with solid tumors control at 88%, subretinal seeds at 82%, vitreous seeds at 67% after an average of 3 sessions. A meritorious procedure have its own set of complications, and they are as follows. While IC is an effective localized treatment, it does not provide systemic chemoprotection. This raises concerns about the potential for undetected systemic micrometastasis, particularly in advanced cases of retinoblastoma. Additionally, the high cost of the procedure is a significant drawback, making it less accessible, especially in developing countries where affordability is a major concern. From a time when eye salvage in advanced retinoblastoma seemed an unattainable goal, to a present where we now offer both globe and vision salvage, the journey has been nothing short of remarkable. It is currently being performed in over 31 countries and stands as a testament to the relentless pursuit of progress, turning what was once impossible into a shining reality.
Eyelid reconstruction is nothing short of an art. The artist, that is the surgeon, must have a sound knowledge of the subject and must have the right tools and the skills to enhance the outcome. Human eyelids are unique areas on our face because of their intricate and dynamic anatomical structure. The eyelids play important roles. They help distribute the tear film across the ocular surface, tear drainage, protection of the surface, and also play a major role in cosmesis. These roles must be kept in mind for adequately restoring the eyelids functionally and aesthetically. Eyelid defects can either be congenital, which can be challenging to repair, or acquired, which can be traumatic or iatrogenic. Familiarity with the myriad of options for reconstruction are critical for achieving optimal outcomes. A comprehensive knowledge of the anatomy and intricacies of eyelid structure is important to restore it as close to pre-surgical parameters functionally and aesthetically as possible. Hence, when we approach the reconstruction, eyelids must never be studied in isolation, but in the context of the surrounding structures, including the blood supply and the nerve supply. Coming to the basics of reconstruction, the very first step is to assess the defect, whether it is partial thickness or full thickness, margin being involved or not, the size of the defect, the location, whether it's central, medial, or lateral, whether the canthi are involved or not, the cranial drainage system involvement, and of course, the age of the patient. Reconstruction of extensive full thickness upper eyelid defects is often challenging. An algorithm that can be followed to choose your option is described here. Not just the width of the eyelid defect, the height and the involvement of the tarsus are important considerations to keep in mind while making the choice. Endpoint to keep in mind for the upper eyelid is to have optimal height and contour to protect the cornea without significantly restricting eyelid mobility. The donor side sequelae should also be acceptable. Large upper eyelid defects that exceed 70% of the eyelid width have traditionally been reconstructed using the Cutler-Beard procedure, which is a full thickness cutaneoconjunctival inferior eyelid advancement flap. Similarly, for large lower eyelid defects, Hughes' tarsoconjunctival flap is utilized. First described by the legendary Wendell Hughes in 1937, which was later published together with his lifetime of work. The teaching is, if you know how to do a Hughes procedure, you can fix almost all large lower eyelid defects. So what if we reverse the stroke of the master? So through this video, we describe the reverse stroke, that is, the reverse modified Hughes procedure, wherein the tarsoconjunctival flap is fashioned from the lower eyelid and used to reconstruct the upper eyelid, highlighting the key surgical steps. A 4 millimeter margin is taken all around the tumor. Fracture sutures are taken with 4-0 silk. Lid margin incisions are given. The skin is incised with number 11 blade. Hemostasis is achieved. Lid margin is cut at the edge, and the lid is reverted to expose the conjunctival side, wherein 4 millimeter margin is then taken using a bipolar radiofrequency cautery. The medial sutures are held together, and the monopolar cautery is used to excise the tumor mass. The excised sample is sent for histopathology for margin control. The eye is closed, awaiting the frozen section report. After confirming that the margin is free of the tumor, eyelid reconstruction is done. The coloboma is measured in the height and the width to decide the size of the advancement flap. Herein, we have a shallow coloboma with a lax skin, which can be easily advanced to cover the defect, forming the anterior lamella. Hence the choice of the reverse Hughes procedure. The lower eyelid is properly everted over a lid spatula. Maximum width extent is marked, and the entire span of the proposed flap, along with the vertical cuts, are cauterized using a bipolar cautery. Using a monopolar cautery, a full thickness tarsal incision is made. Vertical cuts are then made to complete the flap. Subtarsal dissection is done. The tarsoconjunctival flap, thus fashioned, is held to estimate the approximation with the upper eyelid. If any tension is encountered, relaxing incisions can be given. 6-0 Weichel sutures are used, and the bite is taken through tarsus and conjunctiva from the edge of the flap and passed through the tarsal edge of the upper lid coloboma, avoiding the conjunctiva. Same is repeated on the other edge. Central sutures are taken with bite through the tarsus. Collagen-rich tissue like tarsus requires multiple sutures for adequate healing by secondary intention. The eyelid height is fixed, taking care that the bulbar conjunctiva does not get pinched in the bite taken. This is an important step, and the bite is taken through the edge of the conjunctiva from donor, going through the tarsus to avoid full thickness. The height is thus fixed, and that much amount of conjunctiva is donated to the upper lid. Next step is to suture the skin. Here we go in the line of the wound, mark the skin for undermining, and vertical mobilization of the skin muscle flap for anterior lamellar reconstruction. Skin orbicularis dissection is done to create the flap. The skin muscle flap is thus advanced, and skin to skin is sutured using Crowley. The edge is sutured first and then the vertical height. Lid margins are then fixed to the conjunctiva for height and contour. The inferior edge is marked, and the horizontal bite is taken through orbicularis at the same level. It completes the stage 1 of reverse Hughes procedure. Stage 2 is generally taken up after 6 to 8 weeks of stage 1 when adequate healing has occurred. A plain forceps is placed beneath the flap and it is lifted up. Monopolar cautery is used to cut the flap layer by layer. Conjunctiva is cut under tension using a scissor. Excess bulk of the tissue is excised. Glue is used and conjunctiva is everted to form a smooth eyelid margin. The advantages that we gain with this procedure are tarsal support from donor lower eyelid, enhancing the stability of the reconstructed upper lid, thus avoiding any need for tarsal substitute. The advancement of the well-vascularized orbicularis muscle between the skin and the tarsoconjunctival flap reduces scarring to produce a thicker and softer eyelid, and also preserves function, allowing good eyelid closure. Since this is a lamellar flap, anterior lamella of the donor eyelid and the circulation within are not violated. Hence, there is less risk of any complication to the donor site. In conclusion, the reverse modified Hughes procedure with skin orbicularis mobilization can provide an excellent outcome in function and cosmesis for upper eyelid reconstruction.
Orbital dermoid cyst, a benign developmental choristoma. It is the most common orbital tumor of childhood, known to be arising from ectodermal sequestration along the lines of embryonic fusion of mesodermal processes. Approximately 80% of dermoid cysts are found in the head and neck region, amounting to 3 to 9% of all orbital masses. Dermoid cysts are slowly expanding in nature due to the constant desquamation of epidermal lining and secretions of dermal glandular elements. Cytopathologically, the cyst is lined by keratinizing stratified squamous epithelium with lumen containing a collection of laminated keratin debris or hair shafts, or sebaceous glands and sweat glands. Dermoids can be classified as sutural, anterior orbital, deep or posterior orbital, intraosseous, transorbital, and conjunctival, being pernicious or epibulbar. Dermoids predominantly occur in the superotemporal quadrant at the frontozygomatic suture or superonasally along the frontolacrimal suture as asymptomatic, painless, well-defined, cystic, compressible, smooth, mobile subcutaneous masses with or without proptosis, dystopia, ptosis, diplopia, or oscillopsia on mastication, which usually occurs in dumbbell dermoids. The symptoms depend on the depth and extent, and they might rupture spontaneously, inciting an inflammatory reaction leading to preseptal or orbital inflammation. MRI shows rounded lesions with variable isointense material in the lumen with gadolinium enhancement of the cyst wall. CT scan with bone window is necessary to assess the exact location and size and to outline the bony involvement for a decision on the most appropriate surgical approach, especially in posterior dermoids and dumbbell or R-class dermoids. Conservative management, that is observation, may be adopted as these cysts are small, asymptomatic, and are not a cosmetic blemish. However, with functional and cosmetic implications and the possibility of spontaneous or traumatic rupture, surgical excision becomes the treatment of choice. The ideal goal of such surgery is complete removal without rupture. Here is a 4-year-old girl who presented to us with an angular dermoid in the superonasal area. For cosmetic reasons, surgical excision was planned. A skin incision was marked over the site of dermoid after palpation along the relaxed skin tension lines. Skin incision was made with an 11-number Bart Parker blade, and anterior layers were dissected with a blunt denotomy scissor. Change in dissection plane was evident by the change in color. The anterior dermoids are easy to excise if sutural extension is limited and should not be missed as it can sometimes be subtle tethering. Meticulous dissection is carried out all around the cyst, and the thin wall of these dermoids should be kept in mind to avoid intraoperative rupture, especially near the sutural areas where the tissue gets pinched. They are often attached to the neighboring structures like trochlea in the superonasal region, palpable lobe of the lacrimal gland in the superotemporal region, and can sometimes be extracavitary, extending to paranasal sinuses and temporal fossa. After dissection of all the peripheral adhesions, the lesion was securely prolapsed anteriorly with cryostabilization, and the pedicle was dissected out. Hemostasis was achieved and orbicularis was sutured with 60 vicryl, and the skin was sutured with silk interrupted sutures, keeping cosmesis in mind. Complications like periosteal or sutural tether, bony erosion, fistula formation, and the risk of intraoperative rupture should be borne in mind. Here is a case of a 19-year-old girl who presented with a long-standing lesion over the right lateral orbital rim. The CT showed a well-defined thin-walled cystic mass with a relatively broad base, thus indicating towards a possible underlying bony tether. A subraw incision was taken and gradual dissection was performed. Suborbicular gentle dissection was done to go around the cystic lesion. Very careful layer-by-layer dissection was performed and the adjacent structures were dissected off the lesion. Attempt was being made to avoid rupture of the dermoid, as it is extremely thin-walled and an intraoperative rupture can lead to postoperative inflammation. A very thin-walled lesion can be seen and meticulous dissection was carried out. The lesion was secured 360-degree and a beautiful internal glow can be seen here on intraoperative transillumination. The lesion was completely excised, sent for histopathology, and orbicularis and skin were sutured in layers. The surgical management for different dermoids is individualized. Posterior or deeply seated dermoids cannot be easily completely excised and can cause continuous bony destruction and recurrent inflammation. In such cases, marsupialization of the dermoid with removal of the epithelial lining is the recommended alternative. While extensive surgery with en bloc excision is an option, a recent alternative for dumbbell dermoids is minimally invasive foam sclerotherapy with an anionic surfactant, sodium tetradecyl sulfate, with a concentration of 30 mg per ml. Under local anesthesia, the perimeter and epicenter of the lesion are marked, and a wide bore needle is used to aspirate out the contents of the cyst, ensuring complete collapse. Here, 4 cc of contents were aspirated, and 1 cc of sodium tetradecyl sulfate was taken, performing it to 2 cc by modified Tessari-Tourbillon technique. While the foam is being generated, the needle should be kept in place within the lesion. The sclerosant of desired quantity is then injected. We have seen excellent aesthetic results with this technique. To conclude, orbital dermoids, if stable, can be observed, patient counseling and reassurance. If surgery is essential for cosmetic and functional indications, radiological assessment of the adjacent structures is advocated for surgical planning. Complete excision, wherever possible, with an aesthetically appropriate technique is ideal and recommended. And when complete excision is not feasible, adequate measures must be taken to avoid recurrence.
Hello everyone. Let us learn from this video all about a rare and intriguing tumor, orbital intraosseous hemangioma, the clinical features, differential diagnosis, surgical tips and tricks. There are no financial disclosures and the abbreviations used are listed here. Intraosseous hemangiomas are benign vascular malformations that account for less than 1% of bone tumors. The common sites affected are the vertebrae and skull, and orbital involvement is exceptionally rare. They usually present in the 5th decade of life, with a slight female preponderance reported in literature. There is no known predilection for laterality. They can present because of a mass effect that results in globe dystopia, ptosis, proptosis, or a palpable anterior orbital mass. Differential diagnosis of these bony lesions includes fibrous dysplasia, sphenoid wing meningioma, and osteoid osteoma. These can be differentiated by a CT scan, wherein the fibrous dysplasia shows multifocal involvement with enlargement of the bone but reduced bone density. Sphenoid wing meningiomas usually have a bone and soft tissue component that presents as a triradiate lesion. Osteoid osteomas are well-defined bony lesions that match with the density of the adjacent bone. In contrast, the lesion that we're talking about, which is intraosseous hemangioma, presents with a typical expansile bony lesion that has a honeycomb or soap bubble-like appearance. This is because of the presence of the radiolucent vascular spaces that are separated by bony trabeculae. CT also aids in identification of the epicenter of the lesion, which can be the roof, as in the first two pictures, the floor of the orbit, or the zygomatic process of the maxilla. The extent of the lesion is also delineated by a CT scan, as in this image, which shows the complete obliteration of the maxillary sinus by the intraosseous hemangioma. Management can include watchful observation in lesions that are asymptomatic or a surgical intervention in the form of debulking or en bloc excision. When a surgical approach is planned, the bony defect can be left alone, reconstructed primarily, or reconstructed in a staged fashion. Other alternative modalities in highly vascular tumors include a digital subtraction angiography guided embolization, radiotherapy, or sclerotherapy. When a surgical approach is planned, it is based on the epicenter and extent of the lesion delineated by the CT scan. This can be a subbrow approach, an eyelid crease approach for superior lesions, or a subciliary approach for the floor of the orbit or anterior maxillary lesions. In addition to the routinely used instruments in orbital surgery, one must be equipped with a gouge and hammer to allow separation of these lesions from the adjacent normal bone. Since these are highly vascular tumors, the list of must-haves also includes a good monopolar cautery with fulguration tips, bone wax, absorbable gel foam, and tranexamic acid. Let us now look at a few case scenarios. Here is an intraosseous hemangioma of the frontal bone that was approached by an eyelid crease incision, and the tumor was identified with ease. The tumor was then chiseled out and excised en bloc. We can see that the bony defect was not very large, so the edges of the bones were smoothened and primarily closed. In this young lady who presented with globe dystopia and proptosis, a large inferior orbital lesion extending into the maxillary sinus was noted. For her, a subciliary approach was combined with a calver-luck incision through the oral cavity, and the lesion was excised in toto. You will be surprised to know that it did not need a bone graft or reconstruction, but did well with minimal postoperative enophthalmos. Here are two similar cases of the left maxillary sinus lesions. For case 3, a debulking was performed, and for case 4, an en bloc excision. For case 3, the surface of the debulked lesion was covered with bone bags, and the defect after en bloc excision in case 4 was covered with an absorbable mesh. Both the patients went on to do well. Let us now look at the pathology of these lesions. The gross specimens usually show bony tissue which is deep red to brown in color with sieve-like tiny openings. On histopathology, sections show blood-filled spaces that are separated by networks of thick bony trabeculae and fibrous tissue. To summarize, intraosseous hemangiomas are uncommon lesions that can rarely involve the orbital bones. Typical radiological features aid in differentiating them from other bony pathology and establishing the diagnosis. Surgery is indicated if symptomatic or in the presence of a mass effect. Surgical planning should take into account the epicenter of the lesion, its vascularity, the extent of the bone that should be removed, hemostatic measures, and options for surgical reconstruction of the bony defect. Thank you.
The panelists to say that to announce the top three winners and giving their certificates and the winners will come up on stage further.
Okay, so those were amazing videos. I was just saying to Dr. Gambos, I feel next ISO, one of those video presenters should give a talk on how to make such an amazing professional video. So in third place, we have Dr. Vempuluru orbital intraosseous hemangioma. In second place, we have Dr. Bansal, simple to complex orbital dermoids. And in first place, we have Dr. Yerevoy, extrascleral growth of melanoma.
Stage, but the grad students have been able to I couldn't practice to join.
Peruse, Santosh, would you like to come up so we can? And a round of applause to the members who stayed till the end.
We cannot announce the result of the quiz that we conducted yesterday. I request to see with us to come on stage. Dr. Samiksha, are you in the hall? I request Dr. Samiksha to present. First, have Dr. Brian Maybe. Anyone on and in 4 minutes, we have Dr. Maybe said.
Done with the quiz awards? Okay, if I can invite Dr. Vicky Dye to come on up. And if we can have our slide up. Don't think Priscilla is here, but if she is, could she come up? And Prithvi Mithranjaya, if you're here? No. Okay.
So this is just a closing ceremony, a very informal closing ceremony that we would like to have. I would invite Dr. Santosh Munawar on the dais. So on behalf of International Society of Ocular Oncology, we the organizers, Dr. Santosh Munawar and me would thank you. Would like to extend a multitude of thanks for being with us here today. Of course, it has been a great experience for us, a great learning for us, bringing International Society of Ocular Oncology under the leadership of Dr. Dan Gombos in 2024 to Goa. And we tried our best to give you a great experience, a memorable experience, academically and otherwise. I'm not sure how much we have reached in the score of 10, but then, well, the intention intention was very pure and right from the heart, and I hope you all enjoyed. And the biggest success is of this conference is your presence, your enthusiasm, and your contribution to the science in ocular oncology. So we had a great time, and I hope you had it too. So once again, thank you so very much. Thanks a lot. So we are going to show the next venue is in Rio, Brazil in 2026, March. And we are all looking forward to it. And we all keep meeting. And this is what our family come together every 2 years. So we have a small video from the Rio team, which we want to play.
So the dates have been set for the 17th of March to 21. Get the sound,
please.
The sound to the video. They're planning some opportunities in Sugarloaf and Copacabana Beach. So it'll be not just a beautiful venue and an academic venue, but there'll be some wonderful social opportunities as well. And the Brazilian hospitality is known to all. So welcome you all to Rio 2026. And one more time, we want to thank our hosts for putting on a great meeting. And the bar has been set very high. Be difficult to achieve, but now Priscilla and Prithvi have a very high bar to set. So thank you both again for all your hard work.
So it actually really feels bad that the halls are getting empty and everyone is leaving. It's as if a family has come for a get together. And then, each one of you are leaving and it actually feels sad. And I would definitely have the withdrawal syndrome for the next few days. Yeah, so I'll meet you all very, very soon. Dr. Santosh, you want to say something?
Just wanted to remind that the conference app will be live for 3 more months. And all the presentations that we have recorded will be made into clips and they'll be uploaded onto the app. So you can access all the presentations over the next 3 months. The making of ISO, that's a short video clip that Vikram has made.
Just behind the scenes. The real one will come soon.
Okay, so we now adjourn. We wish you all safe travels and in lunch. Thank you again. Now that we're really being 4 years. It's a long haul. But we know the society. Um,